Assalamu alaikum, everyone. I hope you're all doing well, inshallah. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a senior medical student. And inshallah, today, for today's session, we will be covering the Heme Onc crash course, inshallah. Now, this crash course will be a bit of a long one since we're covering a whole block in one session. And I'll divide it into three sections. First one is hematology, where we'll describe all the RBC diseases, WBC diseases, all the platelets and thrombosis diseases. Then oncology, which will deal with lymphoma, leukemias, and then micro, which will deal with mainly HIV and malaria. Okay. So this session, like all of my sessions, will be very interactive. I will ask you guys questions, and at the same time, I will be explaining literally everything and giving you guys key terms to remember for your MCQs, OSPI, and for your SAQs, inshallah. Right, let's start off with hematology. Now, the first concept I want to explain in hematology is hemoglobin development. Obviously, in RBC, we have hemoglobin, and then hemoglobin is heme plus globin. What's very important is the hemoglobin that we have in fetal development and as adults. This is very important. In fetal life, we have a fetal hemoglobin, which is HbF, which is 2 alpha and 2 gamma globin chains, okay? Now, this is important. Why? Is because as a fetus, you kind of need more oxygen and you need it to be delivered to you easier, okay? Now, why do we have HbF? Is this HbF binds to oxygen at a much higher affinity. So that basically achieves that goal of getting oxygen easily. Now, once you're born and postnatally, this gamma chain switches to beta, which is what we have as adults. Now, what is the important clinical implication of this information is if you have a patient who has defects in the beta globin chain or the alpha globin chain, more specifically, let's just say sickle cell disease, you need to give this patient more HbF, hemoglobin F. Why? Is because you want to deliver more oxygen, okay? So when we treat something like sickle cell anemia, we want to increase the amount of HbF because this will cause more oxygen binding and it will help patients with sickle cell. So this is the first concept here. Now, as adults, we have majority of our blood is HbA, okay, which is hemoglobin A, obviously. Now you have a small percentage of it, which is called HbA2, okay, or HbA2. Now, hemoglobin A2, there's a percentage that I want you guys to remember, which is 3.5, okay? If it's less than 3.5, this is normal. We have this, okay? If it's more, then this is a certain pathology that we'll talk about later, okay? And a very minor portion, which is less than 1%, is hemoglobin F. This is basically the embryology of HLS or hemonc, okay? Now, the next thing is going to be blood grouping. Now, blood grouping is important because when you're donating blood and when you're receiving blood or giving blood through blood transfusions, you need to know the blood grouping very well. Now, for blood grouping, we have two different classifications. We have the ABO classification and RH classification. For ABO classification, it's very straightforward. It's just what type of blood you have, which is either A, B, AB, or O, okay? So if you have A blood type, you have antigens or A antigens on the RBCs. Meaning in the serum or in the plasma, you have anti-B antibodies. So can you give B blood type to patients with A? Yes or no? The answer is no. Good. Why? Is because they will cause hemolytic reactions. Okay, good. So anyone who has blood type A, you cannot give blood type B to them. And anyone who has blood type B, you cannot give any blood type A blood to them. Very simple. Now, patients with AB blood type, they have antigens, A antigen and B antigens on their RBCs. This means that their plasma have 0 antibodies, okay? Why is this important? Is they can receive blood from anyone, okay? They can receive A because they have the A antigen and B because they have the B antigen. Now, O is a direct opposite. It doesn't have any antigens, means that their blood plasma has all the antibodies. So this can only receive blood from O. That's as simple as that. Now, the other classification is the RH classification. This is all basic information. For RH, it's either your positive blood type or negative blood type. That's it. This depends on the D antigen, which is this. If your RBCs are coded with the D antigen, you have a positive blood type. If not, it's negative. Why is this important clinically for both of these? Is something called ABO incompatibility or RH incompatibility. For ABO, it's simple. If you have a patient who has an A blood type, if you give them B blood type, they will cause transfusion reactions, which is hemolysis. Easy. The other clinical importance of this is in pregnancy, okay? In pregnancy, you have ABO incompatibility. For example, if the mother has B blood type and the fetus has A blood type, this can cause mild hemolysis in the fetus, okay? That's it for ABO. For RH, same exact thing. You cannot give, for example, a patient with RH negative blood type, RH positive blood, okay? It will cause reaction. Another importance is also in pregnancy. If you have an RH negative mother who has a baby who is RH positive, you will cause hemolytic disease of the newborn. Excellent. Or in other words, it's called RH alloimmunization. Very advanced thing for you guys at this level. However, just know that this is something that exists, okay? Is you have RH alloimmunization, which means the mother, the first pregnancy, okay, she is RH negative. She has a baby that has RH positive. Her blood is now going to start to produce anti-D antibodies in her blood. The next baby, who's also still RH positive, because the father was RH positive or something, since the mother developed these anti-D, this will go to the fetus and damage other blood cells, okay? In the second pregnancy, this can cause basically miscarriage and abortion. This is the clinical relevance of these blood grouping and how you can tell these. What's important for your level now and what you need to do and will come in OSPE is you need to identify the blood types, okay? And we'll take examples of those, inshallah. Now, in this whole session, I will keep asking you guys, what's the first test you will do? The answer will always be CBC, okay? In this whole block, because it's heme-onc block, the first thing you do is CBC. Now, what do you see in CBC? Firstly, we'll take the red blood cell stuff and then the other stuff later. For red blood cell stuff, you have hemoglobin, hematocrit, and RBCs, okay? The main one you look at typically is hemoglobin. If it's lower than the cutoff, then this is going to cause anemia. If it's above, polycythemia. That's it, okay? Now, if you have a patient who has polycythemia, do you need to look into anything else? Typically, no. Okay, you don't. None of these will help you make a differential for polycythemia. Other stuff will, and we'll talk about it when we discuss polycythemia. The other one is anemia. Anemia, there is many subtypes of anemia. So you need to diagnose what types. You do it based on these lab values. The first one is MCV. MCV looks at the size of the RBCs. You guys know this. If it's less than 80, it's called microcytic. If it's above 100, it's called macrocytic, okay? MCH looks at the weight of the hemoglobin. If it's less than the cutoff, whatever the number is, 24, I think, this is what we call hypochromic. If it's between the cutoff, it's normochromic. Above that, it doesn't exist. There's no such thing as hyperchromic. Now, lastly is MCHC. MCHC basically gives you the concentration of hemoglobin. This is not typically relevant, except in two diseases. What are these two diseases? The MCHC would be high. Hereditary spherocytosis and one other. Spherocytosis is the main one. Autoimmune, hemolytic anemia. Excellent. Good. Okay. Perfect. These two diseases, this MCHC will be elevated. Okay. Now, the next thing is called RDW. RDW basically looks at the size distribution of the red blood cells. If you have red blood cells, some are small, some are big, some are medium sized, then the RDW would be high. We'll look at one example of that very soon. Now, what do we call this in terms of like a term for multiple different sizes is anisocytosis. Excellent, good. Now, one other lab value that isn't here is called reticulocyte count. This is important to differentiate anemia into two different types: hypoproliferative versus hyperproliferative. Most anemias are hypoproliferative. Hemolytic anemias are hyperproliferative. Why? Is because you're breaking down RBCs, you want to make new ones right away. So that's why it's hyperproliferative. Now, for reticulocyte counts, it's elevated in hyperproliferative, so it's only elevated or typically elevated in hemolytic anemias. And I'll repeat this again and again, don't worry. Now, the other parts of a CBC will tell you the WBCs and all of the differentials. And we'll talk about each of these lab values or each of these cells in its clinical context, inshallah. Now, for certain diseases, such as hemoglobinopathies, the next thing we do is this. What is this test called? Electrophoresis. Good. Now, in this electrophoresis, you're looking at three values: hemoglobin A, A1, A2, and F. In this patient, what do they have? What is this electrophoresis showing? Remember, the cutoff is 3.5. It's below 3.5 for A2. This is normal. Good. This is a normal hemoglobin electrophoresis, okay? The three values you look at is these three. Now, you may have other stuff that may pop up, and we'll look at that. So hemoglobin F, less than 1, very normal. A2, the cutoff is 3.5. More than 3.5, thalassemia minor, okay, typically. Less than that, normal. Now, you might have hemoglobin S, hemoglobin H, and we'll look into these, inshallah, with each electrophoresis. But make sure you know how to read these and know the normal values, okay? For this, you will 100% get this in OSPE. Now, for anemias, we need to classify it based on the easiest way is MCV, okay? If it's less than 80, microcytic anemia. Between 80 to 100, normocytic, more macrocytic. Let's start with microcytic. Microcytic anemia, remember these two main important causes: iron deficiency anemia, thalassemia. The rest, like, you can kind of forget, okay? Except this one, which we'll talk about inshallah in this context. Then normocytic. Normocytic is mostly hemolytic anemias, early phase iron deficiency, and I'll explain why. Anemia, chronic disease, and then aplastic anemia, kidney disease, acute blood loss. Let's start with this, which has low reticulocyte counts because it's not hyperproliferative. So in iron deficiency anemia, the last thing to change in the lab values is hemoglobin. So in early phases of iron deficiency, it's normocytic normochronic anemia. I'll mention the stages in a bit. Then anemia of chronic disease is basically when you have some sort of inflammation that's happening. Let's just say patient has rheumatoid arthritis or osteoarthritis for a very long time, they might have anemia. Why is that so? Is because their liver is constantly producing a lot of acute phase reactants and stuff, which will cause a decrease in the blood count, okay? Now, in this set of patients, it's very important is that you look at it and differentiate it from iron deficiency. In iron deficiency, if I ask you to do one blood test, what is that going to be? One singular blood test that will diagnose iron deficiency. Ferritin. In iron deficiency, ferritin is low. In anemia chronic disease, it's high. Why? Is because ferritin is an acute phase reactant. Okay? So in chronic diseases, it will be elevated. That's why, just remember, ferritin in chronic anemia, chronic disease will be high. Then we have aplastic anemia, where you'll have pancytopenia, which is all blood types, red blood cells, white blood cells, platelets will be low. Chronic kidney disease, because you have a deficiency of erythropoietin, okay? And then acute blood loss makes sense. Now, for hemolytic anemias, we'll talk about it in its own separate entity because we have multiple ways of differentiating it. Now, macrocytic, two types I want you to know, folate and B12, and we'll talk about them in more details inshallah. Now, you have this first patient that comes to you with a long term, let's just say a few months of feeling very fatigued tired, looks a bit pale, and has these findings. Iron deficiency anemia, good. Now, let's just say this patient also complains to you that they have been craving ice. What is that called? Pica, good, perfect. So what do we call this change in the nails? Polynychia, good, excellent. Now, for patients with iron deficiency anemia, you need to, first thing you do, what's the first lab value that you ask for in iron deficiency anemia? First thing you ask for, before ferritin. First line, always, CBC, then ferritin, okay? So the first thing you ask for is CBC. What do you expect to see in the CBC? Low hemoglobin, low MCV, and low MCH, excellent. And high RDW. Now, let's just say the lab gave you a blood smear, okay, to look at. Here, you see, firstly, small RBCs, okay, so microcytes. You have low hemoglobin, okay, or low MCH, as you can see here, hypochromic RBCs. And then you have these. What do we call these types of cells? Pencil cells, excellent. So this is, another name is elliptocyte, good. Now this is multiple sizes, so this is why RDW is high, or anisocytosis, and multiple different shapes. As you can see, pencil cells, normal round cells. What do we call different types of shapes? Do you guys know? Poikilocytosis, good. So this is what we say, anisopoikilocytosis, good. Tamam. Now you asked for labs, and you got this. You guys already mentioned these, which is low hemoglobin, low MCV, low MCH, good. RDW, you guys mentioned, oh, high. Reticulocyte count, is it high or low? Low, good. How about ferritin? Low. TIBC? High, good. Why? Is because there's still a lot of binding spots on transferrin because there's not enough iron, pretty much. Percent saturation? Low. Serum iron, makes sense, will be low, good. From all of these, what is the first lab value to be decreased in iron deficiency? Ferritin, excellent, good. Then what? These three, then this. Okay, so number one is ferritin. Second thing to go down is all of these, TIBC, percent saturation, serum iron. Third thing, last thing is all of this. Okay, and when you treat it, the first thing to go up is what? Hemoglobin, good. And it's basically the opposite. Perfect. Now, you just diagnosed this patient with iron deficiency anemia. What do you want to do next? Two things. Give iron supplementation. What's the other thing? Very important. Find the underlying cause. Excellent, excellent, excellent. Good. Now, the most important causes, I'll tell you. Let's just say physiologic causes. Now, physiologic cause is very common in female because of menstruation. So in this case, you have the cause, okay? So what you do is just you give iron. Now, the more dangerous ones are the pathologic ones. Now, what is the most common cause of iron deficiency anemia worldwide? GI ulcer, peptic ulcer disease, good. What is the most common cause in developing countries? Hookworms, which is, I think it was called ankylostoma duodenale or whatever. Some other parasite as well. So you have hookworms, good. Now, dangerous causes of iron deficiency anemia, and specifically in elderly who's been losing weight, is cancer, okay? This cancer is most commonly in the colon, excellent, or anywhere in the GI tract, either esophageal, gastric, colon, okay? So that's why you do, for example, colonoscopy, you look and you find it. The main thing is number one, identify the cause of iron deficiency. That's very important. And number two is you treat the iron. You give iron supplements. Now, for iron replacement supplementation, you have all of these. You have oral and you have IV, okay, or parenteral administration. The most common iron supplementation is ferrous sulfate. And remember this fact very well. Ferrous sulfate is the most commonly given iron supplementation? Okay. This is usually asked. Now, other than that, the most highest elemental iron, just remember, is this one, carbonyl iron, if you get some random fact question, okay? Because you never know with these pharma lectures. Now, how much iron should you give in a day? It's around 60 to 120 milligrams a day, and you just basically divide it. So most commonly, what clinicians do is give 20 milligrams 3 times a day. Okay, so you gave 60 3 times. So you gave 20 3 times, which turns out to be 60. Now, very importantly for iron, is you need to give it 2 hours before you eat or 4 hours after you eat, and especially with antacids if you take any antacids. And if you have it, something that we also give with iron is vitamin C because it enhances its absorption. Okay. Now, very importantly, it's a side effects. Side effects, I just want you to remember GI side effects, most common remember is constipation. It's one of the most common causes of constipation. Number 2 is it causes characteristic black stool. Now, also another thing that's not mentioned is it can cause ulceration in the esophagus. So it can cause reflux, acid reflux. Okay, so that's basically oral iron supplementation. Now, if a patient cannot take oral iron from any reason or have very severe iron deficiency anemia, like you cannot treat it alone with oral iron, then you can give parenteral preparations, which is through IV, which you have these types, which is iron dextran, sucrose complex, and these other two. Now, importantly is when you give iron IV is you look out for the side effect, and since it's IV version, it can cause anaphylaxis. Okay, so severe allergic reaction, basically. Okay, and skin staining, severe pain, and whatever with injections. Now, also patients, let's just say, because there's one other thing from this lecture that I did not mention in terms of iron replacement, I didn't include a slide for, is if you have a patient with chronic kidney disease and they have anemia, you can give them erythropoietin, okay, which is a recombinant version of erythropoietin. And the one fact I really want you guys to remember about erythropoietin is its side effect. Do you guys know what the side effect of erythropoietin is? Very important side effect. Okay. Hypertension. Okay. Remember, erythropoietin, recombinant, causes hypertension. Okay. So that's basically that. Is iron deficiency in every slide before this clear? Good. Now you have this patient. This patient has been coming to you with a long time fatigue, looks pale, and has paresthesia and numbness in their hands. Good. Your differential is megaloblastic anemia. Good. You order, the first line is always CBC. You get low hemoglobin, high MCV, and low reticulocyte count. So this is what macrocytic megaloblastic anemia. Okay. You do a peripheral blood smear and you see this. Firstly, you can see big RBCs, macrocytes. And what is this? Hypersegmented neutrophil. Excellent. Good. Now, what investigations do you want to order? B12 folate. Good. What else? MMA, homocysteine. What else can you order? Excellent. Antibodies against intrinsic factor. Perfect. So let's talk about this one by one. Let's just say you're expecting a patient to have folic acid. Number one test to do after CBC and everything, folate levels, okay, B9 levels. If it's low, you diagnose the patient. How about if it's not low, you ask for other stuff, which is you guys mentioned homocysteine and MMA. Homocysteine and folic acid will be high, low, or normal? Homocysteine, high. MMA, normal, excellent. Now B12 deficiency. Obviously, B12 will be low, and then everything else will be high. Excellent, good. Now, one other thing you can order in B12 deficiency, which you can't in folic acid, is antibodies against either intrinsic factor or parietal cells. Okay, perfect. Now, one thing about this is you need to identify the causes of folic acid and B12 deficiency. In folic acid, what are some, firstly, which type of food is high in folic acid? Green stuff. So if you get a question about a vegan, it's never folic acid, unless they're very alcoholic and something. So number one, it's in green leaves. So usually it's not deficient in diet. It's not as easy as B12. That's number one, or it's not as common as B12. Number two, alcoholism, very important. Number three, pregnancy. Pregnancy, that's why we give them folic acid. Even before they get pregnant by at least 3 months, because we want to replenish their folic acid for development of the fetus. It's very important. Other than that, malabsorption and some other causes. Now, for B12, it has very specific causes. Number one is vegan diets. Okay, vegan diet, however, it can take a long time for you to develop B12 deficiency because of a vegan diet. That's number one. Number two is pernicious anemia. Pernicious anemia, as you guys already mentioned, the antibodies, it's basically an autoimmune disease against the parietal cells in the stomach. Now, the parietal cells has two functions. Number one, acid. Number two, intrinsic factor. Okay, those two are the main important functions of the parietal cells. The most important ones from these two is intrinsic factor. Intrinsic factor binds to B12 and allows for its absorption. Where is the absorption for B12? Ileum, good. The terminal ileum, perfect. In the terminal ileum. So, if you have pernicious anemia, you have this autoimmune disease against these intrinsic factors. You won't have this, so you'll have B12 deficiency, no absorption. Number two is if you remove the parietal cells. When would you remove the parietal cells? If a patient did a gastrectomy, surgery, removal of the stomach, or a big part of the stomach. That's number two. Number three is a disease in the ileum. Okay, so for example, inflammatory bowel disease and some other bits, you'll learn it later, diseases can affect the terminal ileum and cause a disruption in the absorption of B12. Okay, so that's basically the important causes that I want you to remember. Other than that, for both of these, if you have a bacterial growth in the stomach or in the GI tract, it can cause deficiency of both, more commonly B12. Now, do you guys know why MMA is high in B12? Okay. So in the odd chain, if you remember from MOL back then, in the odd chain fatty acid, methylmalonic acid gets converted to propionyl-CoA. The main important factor is B12. If it's not there, this will be high. Propionyl-CoA will be, it just won't be converted to that. That's it. Now, important clinical part of MMA is this high MMA will cause what disease? In B12 deficiency. Subacute combined degeneration. Good. Excellent. So B12 deficiency have SCD, which is subacute combined degeneration of the spinal cord. The reason why they have this is because of the high MMA. Okay, that's why in folic acid deficiency, they don't have it. Is this concept very clear? Homocysteine is what causes the vessel disease, atherosclerosis, not this. Let's ignore that fact. MMA causes subacute combined degeneration. It causes damage in the, there's 3 tracts in the spinal cord that gets damaged, but whatever. Okay, is this clear for everyone? Yes, neurological symptoms, which is the subacute combined degeneration, is only in B12. So if you have a patient who's coming to you with paresthesia, numbness, poor proprioception, and for example, poor balance, think of B12. Most common symptoms, paresthesia, numbness. Good. Okay. Now, what do you do with these patients? Very simple. Replace. Obviously, you find the cause, which is very typical, like you'll find it. Then you treat them with either folic acid or B12. Now, for B12, what I want you to remember, it's intramuscular. Okay, and you get it usually every other day, and then once they have replenished stores, then you give it once a month. Okay. That's basically for vitamin replacement for B12 and folic acid deficiency. Now going on to hemoglobinopathies, okay? There's three main ones I want you guys to know, or two main ones here, which is thalassemia, beta and alpha thalassemia. Then you have sickle cell, which is another thing. So firstly, is in hemoglobinopathy, the main concept of the slide is just if you have a mutation, this can cause abnormal proteins, which is the case in beta thalassemia, sickle cell anemia, and sickle cell anemia. These two are the main ones I want you to remember, which is abnormal globin, okay? And this will cause loss of function, mainly in beta thalassemia, or a change in the structure of the protein. So in beta thalassemia, the main important, I guess, mutation that occurs in beta thalassemia is a defect in the splicing, okay, which is mentioned here. Defect in the splicing. This was what causes beta thalassemia, which causes it to lose its protein function. So you have defects in the beta globin chain. For hemoglobin S, it's due to a mutation that happens, a point mutation, which causes a change in the whole structure of the globin chain. That's why it's called novel property or novel change, okay? Which is, you guys know glutamic acid gets changed into what? For valine, good. Okay, perfect. So that's basically this. Now, in the case where you have a decreased amount of a specific protein, which is in alpha thalassemia, okay? Now, do you need to remember alpha thalassemia in detail? No, but just remember one of, I'll basically go over a table that explains it, but it's not really frequently asked, and it's very uncommon and rare to see, okay? But beta thalassemia and sickle cell are very common to see, especially here in this country. Which brings me to this slide. You have two types of thalassemias, alpha, beta. If it's a defect in the alpha globin genes, it's alpha. If it's a defect in the beta globin genes, it's beta. Easy. So you have four alpha globin genes, and basically the type of disease that you have is depending on the number of alpha genes that gets deleted. Okay, so normal has all four, obviously. Silent carrier has just one of them gone. Trait, two of them. HBH disease has three of them, and this is where you start having a lot of symptoms. Now, if you have all four of them, this is incompatible with life, and it causes something called hemoglobin Bart's or hydrops fetalis. Hydrops fetalis is basically the baby will be very edematous, okay, which basically means filled with fluid, okay, inside the amniotic cavity and inside the baby themselves. They have pleural effusion, high amounts of peritoneal fluid, what's it called? Cardiac tamponade and also in the brain, fluid everywhere. This is what we call hydrops fetalis. So why it's called hydrops. And this is incompatible with life. The one that I want you kind of to remember is HBH disease because of a certain appearance that it has. Okay, and I'll explain it later. Then beta thalassemia, which you need to know. So in the beta genes, you either have a decreased function, which is this, or absent beta gene, okay? Normal has both of them. If it's thalassemia minor, one of them is either affected, so decreased function, or deleted, which is a 0. Now, with thalassemia minor, you have elevated A2 above 3.5, and this is very important, okay? Now, thalassemia minor is also called thalassemia trait, which is something you may like hear it as, and it's usually patients are asymptomatic and it's found incidentally. When is it found incidentally? Especially in this country with the premarital screening tests, okay? So that's basically thalassemia minor. Thalassemia major is with both genes are either affected or deleted, okay? 0 or plus, which is basically affected. And this is where it causes severe disease, okay? And we'll talk about its side effects very soon. Now, you have this patient who has anemia and came to you for premarital screening. You do electrophoresis and you see this result. What do they have? Beta thalassemia minor. Good, excellent. Why? A2, above 3.5, خلاص. You say this is thalassemia minor. Good. Now, what is the mode of inheritance of thalassemia? Autosomal recessive. Good. Perfect. Now, let's just say you have this baby who comes to you with these findings. Beta thalassemia major. Good. So what happens in beta thalassemia major? As I said, the two beta genes are either affected, decreased function, or deleted, okay, because of the RNA splicing mutation, okay? Now what happens is they have a very severe decrease in HbA, and they have elevated HbF, okay, basically because there's no hemoglobin A, there's no beta chains, so it gets switched with gamma. That's why. Now, in these patients, they have very severe anemia, okay? And this severe anemia will cause something called extramedullary hematopoiesis, which basically means your body is deprived of normal RBCs, deprived of oxygen. And it basically tells the body to undergo erythropoiesis in places where it's not supposed to be, okay? The most important sites for normal hematopoiesis is flat bones and specifically the pelvis, okay? So it starts doing erythropoiesis, hematopoiesis in places that's not supposed to be, such as the skull, as you can see, and the spleen, which is this enlarged structure, which is marked, and the liver. So this is what we call extramedullary hematopoiesis or erythropoiesis. Now, when it spreads to these basically structures, it can cause a chipmunk face. I think this is what we call crew cut appearance, and then hepatosplenomegaly. Okay, this is characteristic for thalassemia major, beta thalassemia major. Okay, now you do CBC and you see this, which is low hemoglobin, low MCV, low MCV, low MCH, and you see a bunch of these findings, such as what type of cell is this? Target cells. Good. What further investigation would you want to do for this patient? You took CBC, you saw this, and you saw the physical. Electrophoresis, hemoglobin, electrophoresis. Excellent. And this is what you get. What's the diagnosis? Beta thalassemia major, high HbF. Good. How do you want to treat these patients? Blood transfusions, and they need to do blood transfusions for life, okay? Now, the fear of blood transfusions, it's variable, but for the question for its HbA2 always none. Usually it's none. The most important thing to remember for beta thalassemia major is HbF will be very elevated, okay? More than A, okay? This is what you will be given. Now, patients who are undergoing recurrent blood transfusion, what's the feared complication? Very common complication. Hemochromatosis or iron overload. Excellent. Hemochromatosis is basically a state where you have high iron in the body, and this is what we call secondary hemochromatosis, okay? Now, what do you want to do with these patients to prevent hemochromatosis? Chelating agents. Excellent. What is the chelating agent for iron? Deferoxamine. Good. Okay. We'll talk about the chelation agents later. Deferoxamine is the chelating agent for iron. Okay. Good. Now we go to hemolytic anemias. So hemolytic anemias is a state where your RBCs are getting destroyed. Okay. Now there's two ways we can characterize it: is intravascular versus extravascular, which makes it very easy to remember it. Okay. Intravascular is the RBCs are getting destroyed inside the red blood, inside the blood vessel. Simple. Extravascular is in the spleen. Now, step by step, what will happen when you have hemolytic anemia? Number one is what changes will you see in CBC? Firstly, RBC will be down, hemoglobin will be down, MCV and MCH will be what? And hemolytic normal. Good. Normal. Okay, it's a normochromic, normocytic anemia. Reticulocyte count will be high. Excellent. Good. Now, very important markers for hemolysis is number one, LDH. Remember, if you see a lab value of elevated LDH, it's telling you there is, in this body, in this patient's body, there is hemolysis happening, okay? Number two is this hemoglobin, obviously the globin, will later be turned into bilirubin. Good. So this will cause hyperbilirubinemia, and more specifically, unconjugated bilirubinemia, okay? And this will cause the patient to become what? High bilirubin in the blood, jaundice. Good. Okay. They will look yellow or green. And a very typical location is in the sclera. So scleral icterus, or basically jaundice in the eye. Now, because of the high bilirubin that's being dumped in the blood, your liver is going to compensate by producing more bilirubin for your GI. So when this happens, the bilirubin will be precipitated, will condense in the gallbladder where it's stored, and will cause gallstones, okay? Which will cause a lot of other diseases, cholecystitis. Then you have urobilinogen, which will basically be dumped in the urine as well. Now, that's basically the key parts of hemolytic anemias in terms of the lab values that you will see. Now, the two types, as I said, is intravascular, if it's inside the blood vessel, still being destroyed. What are causes of this? Is number one, let's just say, we can divide into two, macro angiopathic. Macroangiopathic is, let's just say you have a patient with let's just say a mechanical aortic valve. So you basically gave them an aortic valve through surgery. And when the RBCs are going over this valve, it's getting destroyed. This is a macroangiopathic. Microangiopathic is very important for you guys to remember, which is, for example, in hemolytic uremic syndrome, TTP, and some others, okay? Now, when these blood cells are going over these areas that have, for example, in TTP, you have the von Willebrand factor, so it gets sheared, it turns into these types of cells, which are schistocytes, okay? And we'll see a picture of this. Now, another thing is serum haptoglobin is very specific for intravascular hemolysis. What is haptoglobin? Haptoglobin basically is released from the liver, and it goes and binds destroyed RBCs in the blood, okay? Basically recycles RBCs, helps recycling. Now, if you have a state where you're having more destroyed RBCs, you have consumption of haptoglobin because it's being used so much that it's no longer there. So that's why you have decreased haptoglobin, okay? Then you have other causes of intravascular, such as autoimmune hemolytic anemias and PNH, and we'll describe those later. Extravascular, simple, and the RBCs has some defect that the macrophage needs to take up. So if you have, for example, spherocytosis, G6PD deficiency, some other stuff, it goes to the macrophage, and macrophage is like, okay, this is not normal. I'm going to have to take you, like, eat you up, and you have hemolysis. Okay? That's hemolytic anemias in a nutshell. Now we'll go over all the hemolytic anemias. So firstly is this patient who's coming to you with a long-term anemia and presenting to you with severe chest pain, severe pain in their arms and legs, and swelling in their fingers. What do they have? Sickle cell. Good. So sickle cell anemia, as you guys already mentioned, it's because of a mutation that happens, point mutation, glutamic acid to valine. Okay, that happens, and you can have HBS, which causes the blood cells to sickle. When do they sickle? They sickle in a state of stress. Okay, when you have, for example, any stress, hypoxia, certain medications, if you go, for example, high altitude, you get sick, this causes it to become more deoxygenated, and they will start to sickle, okay? Now, the fear thing that happens when they start to sickle is it basically causes obstruction or sickle cell crisis. Excellent. So this sickle cell crisis can happen in very specific areas of the body, and they have very specific. Now, obviously, it can happen anywhere. It can cause a stroke. It can cause myocardial infarction. But sickle cell has very typical complications because of this crisis. Number one is called acute chest syndrome, where they have very severe chest pain. Okay, that's number one. Number two is bone pain. Okay, or something what we call osteonecrosis. And number three is in the fingers, it can cause swelling, which is what we call dactylitis. And number three is it can cause priapism, which is basically sustained erection, okay? Because it can't, basically, the venous blood can't go away. So this is basically the complications of sickle cell anemia. Now, what do you see? Firstly, you order CBC, you see anemia, and you see high reticulocyte count because this is a hemolytic anemia. You order a peripheral blood smear, and you see sickle cells. You also see some target cells as well. Okay, so sickle cell disease. What other lab value, or what do you want to order next? Electrophoresis, good. Okay. Now, which of them was in the patient that we just saw? Which one of them is in sickle cell disease? Good. Sickle cell disease is B, which has more hemoglobin S than A. Good. In this one, this is sickle cell trait. Good. So you have more, you still have hemoglobin A. Here, none. Okay. What drug do you want to use to treat sickle cell disease? Hydroxyurea. Why? Increases hemoglobin F. Good. Which basically has affinity to oxygen, so it lessens the pain crisis. Good. Perfect. So that's basically sickle cell disease. Now, how about this patient? I'll give you a clue. It says it right there. Hemoglobin H disease, which is the third one from the alpha thalassemias. Okay. I want you to remember just two things for this. And if it comes with this picture. Okay, this picture will come if this disease will come. What do you see on this picture? Can you just give me what this cell looks like? It looks like spherocytes. Very true. And I respect it, but this is excellent. Good. Golf ball appearance. Okay. If you see this picture, it reminds you of a golf ball. This is HBH disease or alpha thalassemia. Okay. And this is where you have 3 alpha genes mutated or deleted. You have 1 remaining. This is HBH. 4, as we mentioned before, is hydrops fetalis or BARTs. Okay. This is very rare, as I said, but just remember it. It was in your what was it called? LGD. And yeah, it sometimes comes. Okay. Whoops. How about this patient? What do you see here in this image? Schistocytes, good. Perfect. And basically another term for it is helmet cells. It looks like a helmet. Okay. You can try to imagine, I don't even know. But anyways, schistocytes. When do you see this? Two causes is microangiopathic hemolytic anemia or macro. Usually what I want to remember is microangiopathic. What are causes of microangiopathic is, for example, DIC, TTP, HUS. Remember these 3. Okay. Hemolytic uremic syndrome, TTP, and DIC, these 3. Okay. Macro, forget about it. You're not going to get asked though. This micro, you will. Okay. So this is schistocytes. It's basically the RBCs are getting sheared. Okay. Good. How about this patient? For this disease, I just want you to remember these images. I'm not going to explain anything else to it. Good. Hereditary elliptocytosis. Good. Elliptocytes. What does it cause? What does it do? No idea. What I want to remember is the images. Usually it could come as an OSPE question, since your OSPE, I think, is MCQs now. Okay, so it's multiple, like you'll get multiple images, it'll tell you which one is elliptocytosis or whatever. So you pick one. So this is hereditary elliptocytosis. Okay. Now this one, you need to know a lot of details for. What is the disease shown in this image? Good. Hereditary spherocytosis. Excellent. Now, how do you know this patient has hereditary spherocytosis? is by, firstly, let's just say signs and symptoms. You'll have anemia, okay, usually hemolytic anemia. It's extravascular from the spleen. And very important finding that you see in this patient is what? Physical exam finding. Splenomegaly, good. Why? Is because it's going to go to the spleen. These cells are no longer capable to basically go through the splenic sinusoids properly, so it gets eaten up by the spleen. And this causes splenic congestion, so it causes splenomegaly, okay? Perfect. Now, what is the defect causing hereditary spherocytosis? 4 proteins. Anchoring, spectrum, band 3, and 4.2. Excellent. Good. Perfect. Okay. These are proteins that are involved in the external, basically, border of the RBCs, and it causes it to become more flexible. Why is this important? Is in the spleen. It can go through and basically squish itself through the spleen. Without this, it becomes spherocyte. Okay. So that's that. Now, what is the mode of inheritance of hereditary spherocytosis? Autosomal dominant. Excellent. Now, lastly, is how do we diagnose this disease? What's the one thing you want to order to diagnose this disease? EMA, flow cytometry for EMA. Osmotic fragility is a good one. However, the best way, and I want you to remember this, is EMA. Flow cytometry for EMA, which looks at the defect in band 3, band 4.2, and more specifically band 4.2. Okay? EMA. Okay, remember that. How do you treat hereditary spherocytosis? What's the one step in management that easily remove the spleen? Does this fix the spherocytes? Nope. It just removes the splenomegaly. Okay, good. Now, this patient comes to you with a severe acute episode of jaundice, anemia, and they just told you they just took, I should say, anti-malarial drug. G6PD deficiency, good. So G6PD deficiency is when you have, from the name, glucose 6-phosphate deficiency, okay? G6P, glucose 6-phosphate dehydrogenase deficiency. Now, this is important for reduced glutathione, which basically removes and neutralizes the free radicals and stuff. Without this, you will have hemolysis, okay? Now, what's important is remember the kind of, like the triggers, it's basically triggered by something. Very common example that's always given is fava beans, okay? Other than fava beans, you have medications such as sulfa drugs, so some antibiotics, such as fluoroquinolone, sulfonamides, and stuff other like stuff like that. I'm not sure actually if aspirin can cause it, but also antimalarials. Okay. So yeah, that's the triggers. And what is the mode of inheritance for G6PD? X-linked recessive disease. Good. Now, what do you see in this image? Good. Heinz bodies. Good. So in this stain, which is the I always forget the stain, supravital stain, you basically target it to Heinz bodies, and this Heinz body is basically the denatured hemoglobin because of the free radicals. Good. Now it goes to the spleen and gets eaten up. It basically eats up this Heinz body. Then what do we call this type of cell? Bite cell. Good. So this is characteristic G6P deficiency. How do you manage G6P deficiency? Very easily. Avoid the triggers. Okay? Try to avoid the triggers as much as possible. That's pretty much that. Now, there's nothing on the slide because I will give you symptoms and you tell me what the disease is. So this patient, there's no like actual image associated with it. This patient is coming to you and complaining to you that every time they wake up, they see red-colored urine. PNH, good. Paroxysmal nocturnal hemoglobinuria, good. Now, paroxysmal nocturnal hemoglobinuria, this will always come in the exam. this exact statement of waking up and seeing pink, red urine in the morning. Now, it's commonly caused by a triad, or it causes a triad, which is firstly hemolytic anemia. Ignore Coombs negative. Obviously, it is, but what Coombs negative is, I'll explain it later. Pancytopenia and thrombosis. Remember this triad. Now, what causes PNH is it's basically a mutation that causes impaired GPI. What does GPI do? GPI basically, in the surface of the RBC, maintains two specific important CD markers. CD55, and I don't know why I have balloons on my cameras anyways, CD55 and CD59, okay? So CD55 and CD59, basically, if you have a state of infection, one important acute inflammatory, basically, way of killing cells is by the decay accelerating factor through the complements. This will go and basically kill the cells that are causing the inflammation or the microbes or whatever is causing the inflammation. Your RBCs are protected from the decay accelerating factor, or sorry, the membrane attack complex. I said decay, it's membrane attack complex by CD55 and CD59. Okay, they protect it. In PNH, you have decreased GPI or a mutation that causes impaired GPI. If there's no GPI, then there's no CD55 or 59 on the membrane anymore. None of that if you have a state of infection or inflammation, the membrane attack complex will basically destroy the RBCs and causes hemolytic anemia. Okay? Is this concept clear? Cool. Okay. Now, as I said, there has a triad. This is a very, very, very important finding. And labs is very important. It's just they will also give you this word for word. CD55, 59 negative. Or they will ask you, they'll give you these symptoms and you say CD55, 59 negative. Okay? That's it. Now, how do you treat it? It's basically, it just the main important thing about treating it is you basically inhibit the membrane attack complex, C5, the terminal complement C5, which is with this monoclonal antibody, eculizumab. Okay? That's PNH. Yeah, if you say DAF negative or decay accelerating factor negative, that's also fine. Okay? Is PNH clear? You will 100% get this in the exam. I even got this in one of my board exams, step 1. So yeah, this is PNH. Now, you have this patient. Let's just say they have long-term sickle cell anemia. And then you see this, they're basically their peripheral blood smear, and you see this. Good. This is Howell-Jolly bodies, which is a sign of splenectomy. Okay. This is either autosplenectomy, which is spleen is still there, but it's no longer functioning because of sickle cell, because of repeated infarction. Excellent. Or you remove the spleen. So if you have a hereditary spherocytosis patient, you remove the spleen, you could see Howell-Jolly bodies. Okay. What is Howell-Jolly bodies? It's basically DNA remnants that's in the RBCs, which is usually taken up by the spleen macrophages. Since there's no spleen anymore, this never happens, so it's still there. Does it cause a disease? No. Okay. It's just a very fun finding. Okay. Anyways, now how about this? Now this is a bit hard, so I will give you a patient with leukemia. Okay, mashallah. A patient with leukemia is coming to you with episodes of hemolysis, hemolytic anemia. Okay, good. So this is autoimmune hemolytic anemia. Good. Now, what are the 3 findings that you see on autoimmune hemolytic anemia before I explain what it is firstly, you'll see the cells are a bit bluer colored, which is what finding is that called? Polychromasia. That's number 1. You'll see spherocytes, and you'll see some nucleated RBCs. I can honestly would not be able to tell you where it is here, so just believe my word for it. So you'll see nucleated RBCs, polychromasia, and spherocytes. Okay. Now, when you do CBC, hemolytic anemia. Now, very importantly, just like in hereditary spherocytosis, is MCHC will be elevated in this disease. Okay, very important. Tamam. Now, for autoimmune hemolytic anemia, how do you want to diagnose it? Do you know how? Coombs test. Perfect. So this picture was associated with warm. However, you usually don't tell it from the picture. Okay? Usually tell it from the signs and basically what's causing it. Okay? Tell. So, Coombs test. Coombs test, we do it, there's two types, direct and indirect antiglobulin testing or Coombs test. Two important contexts we use it for. Direct, we use it to diagnose autoimmune hemolytic anemia. Indirect antiglobulin testing, we use it for before transfusion. Okay, when we're seeing if the patient can transfuse blood or can receive transfused blood, we do indirect Coombs test. Now, what's the difference between them? And this is a very important concept. In direct Coombs test, we're taking the patient's blood, RBCs, and we're giving them antigens. Now, this RBC, it's one of two questions. Does it have anti-RBC antibodies or not? If it does, it will cause agglutination, which is seen in autoimmune hemolytic disease. Why is that so? It's because in patients with autoimmune hemolytic anemia, they have antibodies against the RBCs, which is IgG antibodies, or IgM if it's cold. If they have these antibodies present, then if you give an antigen that activates this antibody, it will cause hemolysis or agglutination. Very simple. If they do not have this antibody, then if you give an antigen, it does nothing. Is this concept of direct clear? You're directly giving the patient antigens. Just remember it. Okay? Okay, direct, you're taking the patient's, the recipient's RBCs, and you're giving them antigens to see if they have antibodies or not. That's direct. If they have antibodies, it's already bound to the RBCs. So if you give an antigen to trigger that antibody, it will destroy the RBC or cause agglutination. Okay? If they don't have these antibodies, giving them antigens will do nothing. So you'll see no agglutination. Does that make sense? Perfect. Indirect is you take the patient's serum, which has antibodies. Okay? It has antibodies. You give them RBCs, it's the direct opposite. You give them, what's it called? You give them the RBCs plus the antigens. Okay? If they have a positive reaction, then they basically has a reaction to the blood that they're about to receive. Okay? Because the blood that they're about to receive will have the RBCs. Okay? So if their blood has antibodies, okay, let's just say, to make it simple, this patient's A blood type, this patient's B blood type. Okay? This patient has B antibodies. So you're going to give them RBCs plus antigens for B blood type. Okay? Because that's what they're about to receive. If this reacts, that means that they have antibodies against the B blood type. If there is no reaction, there is no B antibodies, you can give them the blood. Does this make sense? If you want me to repeat, I can repeat this because this is a very confusing concept. Okay. The purpose of indirect Coombs test is to see basically to see whether or not you can receive blood or not. Okay. So your blood will have antibodies. Okay. So for example, my blood type is A positive. So I have antibodies against B, right? Let's just say you did not know this patient's blood type. So what you'll do is you'll take the patient's serum, which either has the antibodies against B or doesn't. And the only blood you have is B blood type. Okay, just for the sake of explanation. The only blood type you have is B. So you need to give them B blood type, but you're going to do quickly indirect Coombs test. Okay? So you'll take patient's blood type and you'll take the donor's blood type. Okay, or blood. The patient, you have antibodies, but you're not sure if they have it or not. So what you're going to do is you take the donor's RBCs, which the blood has RBCs, and you add antigen with it, okay? And you see if it mixes or not. If it mixes, or it causes agglutination, this means that the patient's blood has antibodies. So you cannot give them that blood. If it does not agglutinate, that means that the patient does not have antibodies against the blood that you're about to give them. So you can give them blood. Does this make sense? I need a yes or no. تمام. If it's confusing, let me know and I'll repeat again. Okay? But this is very important concept to remember. This indirect Coombs test is for pre-transfusion. This direct is just to diagnose autoimmune hemolytic anemia. It's basically opposite of each other. Okay? Let's move on. So, as I said, you have autoimmune hemolytic anemia. The way you diagnose this is Coombs test. Now, Coombs test, there's two types. There's, the autoimmune hemolytic, there's two types, warm versus cold. Warm, IgG, will cause extravascular hemolysis, typically extravascular, and it's seen in SLE and chronic lymphocytic leukemia, okay? And with certain blood, for certain drugs. For cold type, it's associated with IgM, and it's usually intravascular hemolysis, okay? So that's basically, it can be intravascular and extravascular hemolysis, okay? So that's basically that. And it's seen in CLL, mycoplasma, infectious mononucleosis, okay? Now, this picture basically is showing you the agglutination that we do in Coombs test, okay? So this is a Coombs positive. This means that this patient has autoimmune hemolytic anemia. How do we manage it? Rituximab is one important drug, which is against CD20, okay? Steroids, and you can do splenectomy for warm. For cold, again, rituximab, and just avoid the cold because it happens with cold weather, okay? This is basically autoimmune hemolytic anemia. Is everything clear till now? Okay. Now you have this patient coming to you with low hemoglobin, low WBC, and low platelets. You take a bone marrow and you see a bone marrow biopsy or bone marrow aspiration, and you see this. This is aplastic anemia. Good. So aplastic anemia causes an acellular bone marrow or hypoproliferative bone marrow. As you can see, there's a lot of fat. These cell clusters are low. Okay. So this is aplastic anemia. Aplastic anemia can be caused by infections. Do you know what infectious organism can cause aplastic anemia? Parvovirus B19, excellent. Okay, and it can be caused by genetic diseases. Okay, now one genetic disease that I want you to remember is this. What is this disease? Fanconi anemia. Good. So Fanconi anemia is an autosomal recessive disease that basically causes a mutation in there's an FANC gene that causes musculoskeletal manifestation, typically affecting the thumb. So it can cause either basically division of the thumb or multiple or less numbers, and can cause more skeletal malformations. And it can also be associated with skin lesions such as cafe au lait spots and some other stuff. Now, these patients will have aplastic anemia. Do you need to know this disease? Yes. Okay. This is a very important cause of hyperproliferative anemia. Okay, because of it's aplastic anemia. Okay. That's basically that. Now we'll go over just a quick summary because we went through a lot of diseases. But let's just say this patient, pallor and cholinergia. What's the first line lab you do? CBC, good. Second line, ferritin and iron studies, good. What's your diagnosis if ferritin is low? Iron deficiency anemia, good. Pallor and beefy tongue, or what we call glossitis. What's the first line lab? They have pallor. So what do you want to do? CBC. Second line, B12. Good. Excellent. Okay. So if it's low, B12. If it's low B12, B12 deficiency. If they have borderline normal B12, what do you want to order? Okay. If folate is normal, what do you want to order? Intrinsic factor antibodies one. What are two other that you can order? MMA and homocysteine. Good. What I want you to remember, first line, CBC. Then to diagnose B12, B9 deficiency is you order B12, B9 deficiency. If either of them are low and you're suspecting one of them, then you order MMA and homocysteine. If you're expecting B12, you can add on the intrinsic factor antibodies. Okay? That's basically this. Now, if you have a patient with chronic disease and they have pallor, what's the first line lab you do? CBC. Second line, ferritin, which will be low or high? High. Good. Now, how about pallor with bone pain? Let's just say with splenomegaly, I think. CBC, then second line. Electrophoresis. And what's the diagnosis? Sickle cell. Good. Pallor and jaundice. CBC, second line. Second line is LDH, bilirubin, reticulocytes with first line with CBC. And let's just say you're suspecting, let's run through everything. If you're suspecting G6PD, then you order G6PD levels. If you're suspecting hereditary spherocytosis, then what do you do to diagnose it? EMA, good. If you're suspecting paroxysmal nocturnal hemoglobinuria, what do you do? Flow cytometry to CCD 55, 59, good. And then Coombs test to autoimmune. Mild pallor, no symptoms. I think this is thalassemia minor, so I'll just give it to you. And then this one, last one, is simple. CBC first line, second line is do electrophoresis and it's high F. Okay, good. Now, chelation therapy, basically the whole concept of chelation therapy is you're giving medication to go bind a specific element in the body. So for example, common elements that you'll see elevated due to something, copper is one, iron is another, zinc, arsenic, and lead, okay? These are five. Zinc, don't worry about it, but lead, copper, iron, and arsenic are important terms, okay? In iron overload, we already mentioned, for example, someone who's taking a lot of transfusion, you have these two, okay? Deferoxamine and deferasirox, okay? These two are given, okay? This is more parenteral, so it's IV. So for example, if someone has hemochromatosis, you give them this to treat it. If not, then you can give this to patients with blood transfusion, which is deferasirox, okay? Now that's basically that. Now, if you have a patient who have arsenic poisoning, high amounts of arsenic, then you can give dimercaprol, okay? Or if they have mercury, copper, lead poisoning. Copper, the best treatment is penicillamine, okay? Wilson's disease is basically a state where you have high copper in the body, okay? Just for you guys to know what Wilson's disease is. And it's a very important cause of liver cirrhosis. And we'll inshallah cover it in GI, okay? So you give penicillamine to these patients with Wilson's disease, okay? Now, calcium disodium acetate is for lead in children and adults, as well as you can give dimercaprol as well. Both of them can be used. And it's basically for lead poisoning, and that's pretty much that. Okay, simple. What you guys need to know for your exam is you're going to give you an element that's elevated, either copper, lead, arsenic, iron, and you will choose one of these. Okay? If it's copper, which one will you give? Penicillamine. What's another agent you can give if penicillamine wasn't there? BAL, British anti-whatever, leukocyte, or dimercaprol. Good. Iron. If they have acute hemochromatosis, you need to treat it parenterally. Deferoxamine, if they're going through transfusion, you want to give it to prevent, to reduce the overload. Oral form, deferastrox, good. And then if they have lead, calcium disodium acetate, or BAL, okay? That's basically chelation therapy. We're done with RBC disorders. Everything good? Good. Okay, that was a run through of a lot of lectures. Let's now WBC disorders. Okay, WBC disorders, very easy. It's just one lecture plus obviously all the cancers that can happen from these. But WBC disorders, if it's high, you can call it philia or cytosis. Okay, low, penia. Okay, so neutral philia is elevated in acute inflammation. That's number one. So infections and some other stuff, and obviously malignancies, obviously. Neutropenia is very important for you guys to remember. Neutropenia is when you have low amounts of neutrophils. Now you have two forms of it. You have something called febrile neutropenia, which is very severe neutropenia, which is usually below 500. Okay. Now this febrile neutropenia, what's important about it is patients can get very sick and infected with many hospital-acquired infections, such as Pseudomonas, Candidiasis, and Actinobacter. Okay, and obviously Candidiasis and what was the other one? Aspergillosis. Okay, these patients can get very sick, and obviously they don't have a good immune system because of neutropenia to fight it off. And this is commonly seen in hospital settings. So the patient is being treated for something and they have febrile neutropenia. Okay. So you have congenital neutropenia. There's a lot of primary immunodeficiencies. Well, some of them can cause neutropenia. It's your first immuno lecture. Just skim through them. Then you have severe infection, splenomegaly, chemotherapy drugs obviously will cause bone marrow suppression, which will cause neutropenia. Now, eosinophilia, allergic diseases, atopy. So for example, asthma, allergic rhinitis, eczema and dermatitis. And then you have anaphylaxis and hypersensitivity reaction, which is type 1 hypersensitivity reaction. Okay, and parasites can also cause it. Penia is usually very similar to neutropenia, where you have, for example, let's just say chemotherapy and stuff that can cause suppression. Monocytosis, infection. Penia, just remember steroids. Actually, you don't need to remember monocytosis or penia that much. Lymphocytosis, viral, fungal, and parasitic infection. Penia is immunodeficiency, and very important cause is HIV. Now, one more type is basophils. If you have basophilia, what are you suspecting as a disease? CML. Good. I just want you to remember basophilia, if you see it, CML. Okay? Other than that, ignore them. From this slide, what I want you to remember is the neutrophils. Neutrophils, specifically neutropenia. Okay? And here, lymphopenia, very important cause is HIV/AIDS. Okay? This slide basically sums up one entire lecture for you. Okay? Now, that's it, WBCs, because a lot of it is just cancers, and we'll go over it in the oncology section. Okay, yeah. So recovery of monocytosis, recovery of neutropenia, you can see monocytosis because your bone marrow is being active now, so it's going to dump out a lot of blood cells, including monocytes, so you have monocytosis, which is an important finding in recovery phase of neutropenia. Okay. So now, bleeding disorders, you have coagulation disorders versus platelet disorders. What I want you to remember is platelet disorders are more superficial infection, superficial bleeding. Coagulation is deeper bleeding. Okay? So platelet thrombocytopenia can cause mucosal petechiae, mucosal bleeding, and petechiae. Very important. If you see petechiae, you will suspect thrombocytopenia. If you see coagulation diseases, it's internal bleeding. Very commonly is in the joints, okay? Specifically the knee. If you have hemarthrosis, you suspect a coagulation disease. and we'll talk about which one later. Okay, that's basically the slide. Let's talk about platelet disorders. Now, platelet disorders is the first thing that happens in hemostasis, okay? So first thing that happens, you have platelet adhesion, then platelet aggregation, then you'll have the coagulation factors that continue causing the aggregation, okay? So platelet disorders, commonly, firstly, two things you look at is platelet count, which should be low if you have thrombocytopenia, or normal if you have platelet function diseases. And that's number one. Number two is bleeding time. In any state, either functional diseases or disorders of platelets or thrombocytopenia, the bleeding time will be elevated, okay? And it can cause, as you said, mucosal bleeding or petechiae, okay? Let's take the two functional ones first. First one is Bernard-Solier syndrome, which is basically a defect in the GP1B, which its main function is to bind to von Willebrand factor to cause adhesion, okay? So you have decreased platelet aggregation because it's not going to adhere anymore. And a big important factor that you can see here is it can cause big platelets, okay? The way I think of it is because the platelets are no longer able to adhere to the endothelium, it kind of clumps up in the blood a bit, and then it can cause bigger size platelets, if that makes sense. And the platelet count will be low to normal, okay? Now, Glanzmann thrombasthenia will basically cause a defect in GP2B3A, which its main function is in aggregation. So this will cause defective platelet plug formation, defective platelet aggregation, and you diagnose it with platelet aggregation studies. And I'll show you a picture in the next slide. Now, immune thrombocytopenia is basically a disease where you have antibodies that's against platelets. Now, there is two forms of ITP. I will give you a scenario, and you tell me which form it is. A child had an infection and then has petechiae. Which one is it? Acute or chronic? Acute. Good. Acute ITP, acute immune thrombocytopenia, is usually 3 weeks within an infection. A viral infection, something, they form antibodies against these platelets and they have thrombocytopenia. Okay, this is a very important one. Number two is chronic. Chronic, if you have a female, typically a female, over a course of months, has thrombocytopenia and it's associated with the anti-GP2B3A antibodies. And usually these patients have some sort of autoimmune diseases or leukemia, okay? This is acute versus chronic, what's it called, ITP, okay? This is very important. Now for treatment-wise, if you have acute, treat it with IVIG, okay? It's one of the best ones to give. If it's chronic, you can give the rest. Now, steroids can be used in both. If you have a patient who has acute ITP, you give them IVIG, which is IV immunoglobulins, and it doesn't work, then you can give them steroids. For chronic ITP, you can give steroids, IVIG as well, and rituximab. Okay? Ignore the rest, you don't need to know. Does ITP make sense? Acute versus chronic? You will get a question for it. Okay? Acute, a child with infection. Chronic, female with some other disease, long-term thrombocytopenia. Antibodies against this. Okay? Cool. Now, this is an aggregation study, platelet aggregation study. Very simple. This is the blue, which is the normal. This is the patient with, let's just say, Glanzmann thrombasthenia. You see, for example, you take the patient's blood and you give them certain stuff that will cause platelet aggregation. So, for example, ADP causes activation of platelets. Adrenaline causes activation. Collagen will basically expose von Willebrand factor, and if it's there, it can cause adhesion and aggregation. Risocetin is basically stimulates the binding of von Willebrand factor to GP1B, okay? And basically causes the adhesion, then later on aggregation. The main gist of this slide is you'll have markedly decrease in everything because it's no longer being able to aggregate or adhere, okay? That's basically that. And you will get this in the exam, okay? Now, going next to the von Willebrand disease. No, you don't need to know the function of each. That's just for the sake of explanation, that's why I mentioned them. But do you need to know the function? No. Okay. So for von Willebrand disease, it can cause a platelet and coagulation disorder. Okay. Now, platelets, why? Is because von Willebrand disease, if it's not there, okay, it's not going to be able to adhere. Platelets are not going to be able to adhere. So you'll have elevated bleeding count. Will platelet count be affected? No. Okay, so it'll be normal. Von Willebrand disease, platelet count will be normal. For bleeding time, because of a functional platelet disorder, which is platelet won't be able to adhere to von Willebrand disease or von Willebrand factor, sorry, because there's no von Willebrand factor. Okay. Now, von Willebrand factor also carries factor 8. Okay. So because of factor 8 deficiency, you will have an intrinsic pathway coagulation defect. It's needed in the intrinsic pathway. So the intrinsic pathway marker that we use is PTT, and it will be elevated. Okay, if you have factor 8 deficiency in von Willebrand disease. Now, this is an autosomal dominant disease and so on. What I want you also to remember from this disease is there's 3 types of von Willebrand disease. Type 1 is when it's decreased in amount, decreased, not absent. Type 2 is when it's normal amount, but decreased function. And number 3, which is a severe one, which is absent von Willebrand factor. Okay. Now, treatment-wise, you can give von Willebrand factor concentrate or desmopressin, okay, which basically acts like it. Okay. That's basically von Willebrand disease in a nutshell. Now, another disease, I think it's another slide, but I think it's another slide. If not, I'll mention it later. Now, you have this disease. A patient comes to you with basically bleeding, basically telling you that they have severe joint pain, and it happens a lot. They have bleeding whenever they brush their teeth, and they tell you that their uncle had the same disease or same symptoms. Hemophilia. Which one do you expect is this? A. Why A? Most common. Good. Excellent. So this is hemophilia, either A or B. Most likely A. Okay. Which causes hemarthrosis. Okay. And this hemarthrosis over time can cause joint abnormalities and basically structural disease. Okay. So hemophilia, there's 3 types, A, B, or C, and this is a coagulation disease. So it's one of the coagulation factors in the coagulation cascade. A is a factor 8 deficiency, B is factor 9 deficiency, C is factor 11 deficiency. Now, the mode of inheritance for A and B, and I want to remember, is X-linked recessive. So let's just say a male, a father, is a carrier for hemophilia A. What are the chances that their sons would be affected or be carrier? The mother is normal. The father is a carrier. What are the chances that their sons would be affected or a carrier? Son. Why? Yeah, no. No carrier for males. Why? Is because the male, the sons of the father will get the Y chromosome. Exactly. They have to have the Y chromosome. So they will get the X chromosome from the mother. Okay? That's why they'll be normal. In female, it's 25% across the board. For females, so if the father had a carrier, their daughters will be affected, okay, or be carriers, okay? If that makes sense, because their sons have to get the Y chromosome from the father, so they won't get the X, okay? That's why in hemophilia A, if it's the father, then their sons would be normal. 100% would be normal, okay? And then if it's hemophilia C, it's autosomal, yes, hemophilia A and hemophilia B is X-linked recessive. C is autosomal recessive, okay? But C is very rare and you'll never see this. Now, treatment, very simple. If you have hemophilia A, what do you want to give them? Very easy. Factor 8. They have hemophilia or desmopressin, which is also good. Or you give, if it's hemophilia B, factor 9, C, factor 11. Easy. Okay. Now, vitamin K deficiency is another one that I want you to remember. Vitamin K deficiency, it's just basically where you have a defect in the vitamin K depending factors. This can happen in two conditions or two states typically, actually more than that, three. Number one is if the patient is on warfarin, they can get vitamin D's factor deficiency, not the vitamin K. Number two is in newborns, they can have vitamin K deficiency, so we give them injection. Number three is vitamin K is a fat-soluble vitamin. So if you have, for example, a case where you don't have fat absorption, okay, anything in the GI that causes decreased fat absorption, vitamin K is one of them, okay? It can cause vitamin K deficiency. So what is important about vitamin K is it can cause decreased activation of the vitamin K dependent factors, which is factor 2, 7, 9, and 10. Okay, and protein C and protein S. Okay, that's basically all I want you to remember for these two diseases. Is everything clear till now? Okay. Then we have the microangiopathic hemolytic anemia or the thrombotic microangiopathies. There's two of them, okay? TTP and hemolytic uremic syndrome. TTP is basically, now I'm gonna actually give you, I'll actually test you guys before I explain. If you have a patient with hemolytic anemia, thrombocytopenia, and have neurological symptoms, which one is it? Is it TTP or HUS? TTP. Remember neurological symptoms. Good. Now, if they have thrombocytopenia and obviously thrombosis as well, and hemolytic anemia, and they have bloody diarrhea with kidney failure. Hemolytic uremic syndrome. Good. Excellent. So, TTP is a state where you have thrombocytopenia, but it can cause thrombosis. Okay, why? Is because of consumption, basically. I'll explain this. In TTP, you have a deficiency or inhibition of ADAMTS13. What does ADAMTS13 is basically if you have, specify, just draw this. In the blood vessel wall, you'll have von Willebrand factor. Now, von Willebrand factor will keep on growing, and then you'll have this ADAMTS13 to break it, cleave it. If you don't have ADAMTS13, the von Willebrand factor will keep on growing like this. So easily, platelet can come and adhere to it and cause thrombosis. And because of amount of platelets that's binding to this von Willebrand factor, it can cause thrombosis and consumptive thrombocytopenia, which is basically it's being used a lot. Okay, so that's basically, and because of stuff happening over here, it can cause microangiopathic hemolytic anemia. As RBCs are moving here, it's going to get sheared and cut. Okay. Now, it can cause acute kidney injury because this can happen in the renal vessels and can cause renal infarction and basically renal damage. Okay. This is TTP. In hemolytic uremic syndrome, it's typically in children, and they have one of two infections, either E. coli, which is something called enterohemorrhagic E. coli, or Shigella. Okay, these two. These two secretes a Shiga toxin or Shiga-like toxin in E. coli, which causes endothelial dysfunction. When you have endothelial dysfunction, what will happen is you'll have exposed subendothelial collagen, von Willebrand factors there, platelets adhere, thrombosis, and bleeding. Okay? Hemolytic uremic syndrome. Now, the symptoms that's differentiating this is in TTP, you'll have this triad, which is in both of them, plus neurological symptoms. And you'll also have fever, but neurological symptoms are very important. In HUS, you have bloody diarrhea. Okay, because basically Shigella and EHAC causes bloody diarrhea. It's caused by eating, for example, undercooked meat. Okay. Now, the treatment of this in TTP, you give them plasma exchange, steroids, and rituximab. In EHAC, supportive antibiotics. Okay. Are these two diseases clear? Perfect. Now, you have this patient who's coming to you with this skin finding and has told you that they have repeated first trimester abortions. Antiphospholipid syndrome. Good. What are the 3 antibodies that you test for antiphospholipid syndrome? Anticardiolipin, that's one. I'll give you one more. Lupus anticoagulants, and there's one more. Beta 2 glycoprotein. Okay? These 3 antibodies that you test for. But basically, is this lupus anticoagulant specifically, or antibody, binds in the placenta to beta 2 glycoprotein or beta 2 microglobin. I forgot which one it is. I think it's a glycoprotein, and basically causes thrombosis there in the placenta. That's why it can cause repeated first trimester pregnancy loss. Now, what is this finding that you can see here in legs? Okay, this finding is livedo reticularis. Okay, it's not specific, but it's commonly seen in patients with lipid syndrome. Okay, and antiphospholipid syndrome is associated with other autoimmune diseases such as SLE, rheumatoid arthritis, and stuff like that. SLE patients would usually have this. Okay, and I'll talk about this again next block. Now, before we wrap up heme, we have blood transfusions and transfusion reactions. The thing about blood transfusions is you give it in a state where the patient needs blood. Easy. So when would you give recurrent blood transfusion is in patients with thalassemia, for example. Acute blood transfusion is usually indicated in when you have, for example, a patient with acute blood loss. They basically had a road traffic accident, trauma, and they're bleeding out. And if their hemoglobin is less than 7, for example, you need to give them blood. Okay. If they have, for example, thrombocytopenia, not ITP, do not give platelets to ITP, then you can give them platelets, okay? FFP basically has a bunch of coagulation factors. So if you have a patient who was taking warfarin, heparin, something, then you can give them it, okay? Cryoprecipitate has some factors, and fibrinogen, ignore basically these two. But anyways, the point is you don't usually want to do blood transfusions because it can cause so many transfusion reactions, which we'll get to. You only give it in the state that the patient really needs it. For example, if they're bleeding out and you need to give them packed RBCs, okay? And there's a cutoff, which is hemoglobin of 7 and whatnot, okay? I don't think you need to know that. Now, when you want to give a patient blood, you need to do certain things. Number 1, cross-matching. You check ABO, you check RH blood type, and you make sure that the patient has the correct blood type. Okay, that's number 1, or compatible blood type. Number 2 is you can do indirect Holmes tests, and I explained why. Okay, you basically, if you don't know their patient's blood type, without doing the blood type, and you imagine you need a fast and you can't do ABO or something, if it takes time and you want to do indirect Holmes test, which also takes time, theoretically, you can do indirect Holmes test, which will tell you if you can give it or not. And that's basically that. And another thing you need to do is to screen for infectious diseases. There is 5 organisms that can easily be transmitted in blood transfusion. I want you to memorize these by heart. HIV, hepatitis B, hepatitis C, what else? There's 2 more. Malaria and syphilis. Okay, good. Perfect. HIV, hepatitis B, hepatitis C, syphilis, malaria. These 5 are very important infectious diseases that can spread through blood transfusions. In GI, we will discuss about hepatitis B, hepatitis C. HIV, I'll discuss it at the end of this crash course, okay? Remember these very well, okay? Now, as I said, one thing you want to do is blood grouping. This is the basic way we can do blood grouping. We take the blood from the patient and we just put it here and we see what type of blood group they have. If it's low or if it's basically down here, it's negative. If it's up here, it's positive, okay? So this will look at the A antigens on the RBCs, A or B antigens, if they have the antigens or yes or no. These two will look into the antibodies in the serum, okay? This will look at the RH group, okay? So over here, do they have the A antigen or A blood type, yes or no? No. Do they have B? No. So what type of blood do they have? O. And then they have RH positive. Excellent, good. And do they have the antibodies against A and B? Yes, cool. That's it. This patient, tell me their blood type. AB positive, good. Now this is a mother and this is a fetus. What's the mother's blood type? Oh, neg. Good. What's fetus? Oh, positive. What's the feared complication of this? Hemolysis or hemolytic disease of the newborn. Good. Excellent. Now, transfusion reactions. I hate this. But anyways, for transfusion reactions, just remember this. There's two types: acute, chronic, autoimmune or immune related, non-immune related. Okay? This is how we differentiate it. That's number one. I want you to remember most of the acute causes. I don't want you to remember any of the non-immune causes. None of them is related. It's usually just infection. And number two is for the chronic ones or the late complications. There's one I want you to remember. Okay. So, generally speaking, what will happen to a patient when they have a transfusion reaction? They'll have signs and symptoms of transfusion rejection or transfusion reaction, which is fever. They can have, for example, chills, hypothermia, or sorry, hypotension, hypertension. It's either one of those. Skin reactions, okay? And they'll have dyspnea, okay? Shortness of breath. This is the general findings that you'll see in transfusion reactions, okay? This is the general stuff that you'll see. Now, and anaphylaxis, which is you'll have bronchoconstriction, bronchospasm, flushing of the skin everywhere, no breathing, okay? That's another sign that you might see. Now we'll go over it. Number one is acute hemolytic transfusion reaction, which is one of the causes that happens immediately. Okay, immediately when you're giving blood, rapid, during or up to 24. If you have a patient in a case that develops a reaction that's immediately after, this is acute hemolytic transfusion reaction. Why is this so? Is the donor's RBCs are destroyed by the recipient's antibody. Why is that so? ABO incompatibility. That's why we do indirect Coombs. Okay. If the patient is AB or A blood type, and you're giving them B blood type, they will have acute hemolytic transfusion reaction. This is typically rare nowadays because we check for all of this before we give patient blood. Okay. It's rapid onset, which would cause all the stuff that we mentioned. And the very easy thing we do is just stop the transfusion. And we do Coombs test. In this case, it says direct. Don't matter. It doesn't matter what you do here. Okay, and then you just basically, if the patient's complicated, if they're basically very hypotensive, then you give medications, fluids, and stuff like that. Okay, and you treat the complications. Is acute hemolytic transfusion reaction clear? We're gonna go one by one. Why it happens, when it happens. Good. They're all intravascular, yes. Okay. Next one, febrile non-hemolytic transfusion reaction. This one is basically this. The donor is receiving the recipient's blood. In the recipient's blood, there's WBCs, okay? Now, when you're giving the blood, the WBCs could be either old or could be damaged during the transfusion, okay? When this is happening, you'll have cytokines being released from these WBCs. When these cytokines get released from the WBCs, it will cause a reaction in the recipient. That's it. This can happen during, but this is the most common one during, or most important, like characteristic one during, or up to 6 hours, and can present with fever, chills, headache, and whatnot. Very important is just stop the transfusion. Okay, until this is ruled out, then you can give keep giving it. And then you can use leuko-reduced blood products. What is leuko-reduced blood products? Is blood without WBCs. Easy. Okay? Is this one clear? Good. Next one, anaphylactic. Anaphylactic, easy, is you have IgE in the donor's plasma reacting to the recipient. The donor is receiving recipient blood. Now the recipient, okay, wait, I confused myself. Sorry, let me restart. Now, the recipient, the patient who's getting the blood, has antibodies, which is IgE. And basically, when you're getting blood from a donor, you're getting proteins with it, usually. And this can cause a type 1 hypersensitivity reaction, which will cause anaphylaxis. Okay, and this is usually due to IgE. This can be sudden and can be seen with features of anaphylaxis. What is that specifically? Is shortness of breath, bronchospasm, severe bronchospasm, so patient can't even breathe anymore, and flushing of the skin, plus urticaria, which is basically skin lesions. Okay, this is what you see in anaphylaxis. How do you treat anaphylaxis? Firstly, stop giving blood. That's number one, and epinephrine. Give epinephrine. Okay, again, the blood that you're receiving, the recipient is receiving, and antihistamine is usually in the minor one. In anaphylaxis, antihistamine is not usually useful. Okay, which we went to a now minor allergic reaction. It's just a very, very minor one. It's the most common type. This one and the febrile, both of them. This one is the most common overall. This one is a common allergic type. And it's very, very like, so this one is not as severe and life-threatening. It's just you give antihistamines and you stop it initially and then restart slowly. Okay. Anaphylaxis is severe. You stop, you treat with epinephrine. Okay. Are these two clear? This one is minor, this one is very severe. Okay. Now, transfusion-related acute lung injury, TRALI, is basically this. You're giving blood to a recipient. This recipient, in their lungs, neutrophils are going to get activated by stuff in the donor's blood. Okay. That's basically the gist of it. You're giving blood, the recipient, I should say me, I have neutrophils in my lungs that's being active by something in the blood that I'm getting. That's it. That's the basic gist of it. Now, this TRALI can cause acute lung injury, okay? And can cause NCPE, which is basically non-cardiac pulmonary edema, okay? So you'll see respiratory distress, but with nothing else, okay? Respiratory disease, okay? It affects the lungs. Neutrophils in the lungs are being activated by something in the donor, okay? Donor blood components, okay? Basically what you do is immediately stop and give respiratory support. Is this clear? Very simple one, okay? Lastly is delayed hemolytic transfusion reaction and whatever. This one probably won't come. Now, another one that I want you to remember is a late manifestation of transfusion reaction. Happens 4 to 30 days later. It's graft versus host disease. Now, graft versus host disease is basically lymphocytes, WBCs, from the donor is going to attack the recipient's blood or recipient's tissue. Okay, this is graft versus host disease. It's donor lymphocyte damaging affect two specific or I don't know if this was mentioned to you guys, but it can affect two specific organ systems, the GI and the skin. Okay, so it can cause GI upset, diarrhea, vomiting, nausea, and skin lesions. Okay, and also very commonly, actually this is in transplants, so forget about that. But it can affect the GI and it can affect the skin. Okay, and it happens 4 to 30 days after. All of these usually happens acute. Okay, it's basically the lymphocytes will just damage the skin cells. Okay, and it can cause, for example, skin lesions. Why does it occur more in relatives? Okay. The reason, my guess to why it occurs more in relatives is because here in this case, you'll have the white blood cells from the donor is attacking recipient cells. The reason why it happens more in recipients or in relatives, sorry, is because the very close resemblance of the CD markers in the tissues, okay, in relatives. So in graft versus host disease, good that you mentioned it, I'll mention that. But in graft versus host disease, it happens more in relatives because of this association. Is that in relatives, their tissues are very similar. So leukocyte, when you give it, it just reacts to it. The actual underlying reason, no clue. Okay. So that's that. That's just how I think of it. Now, the next one, which is not mentioned in this table, is transfusion-associated circulatory overload. When you're giving a lot of blood, it's going to cause circulatory overload. Okay, there's a lot of blood now that's being given. The difference between this and the lung injury is in lung injury, it's manifested in the lungs itself. In circulatory overload, you'll have, for example, effusions, and you'll have, for example, transudative pulmonary edema. Here, it's exudative because it's inflammatory. Does this make sense? Good. Do these all make sense in blood transfusions? Because I know it wasn't a lecture. Okay. Not gonna lie, I did not know that. Good. The rest of it. Blood transfusions, are we good? Good. And we're done with heme. Next is onco. So, do you guys have any questions from heme? Very large session so far. Okay. Now onco, which will be inshallah very smooth because it's a lot of just quick recognition. Okay. For example, what is this? Okay, but we'll talk about this specific one later. Now, let's go into it. Or do you guys want to break? Or just dive straight in? Break? How much? You want 5 minutes? Okay. So we'll come back at 9. Okay. Or 9:02. All right. Now the second part will be oncology. Okay. So the first thing is a normal lymph node, just a basic anatomy and histology of it. Is you'll have the cortex, which is the external part of the lymph node, then the internal portion, which is the medulla. Okay. Now, between the cortex and the medulla, you'll have the paracortex. Now, it's important to remember what types of cells you have in the cortex and the medulla. Firstly, in the cortex, you'll have follicles, primary versus secondary follicles. Secondary follicles have germinal centers. The main cell in the cortex is what type of cells? B cells, okay? B cells, good. Primary follicles don't have germinal centers. They are composed of naive B cells, okay? They still have not met an antigen yet. In secondary, they have, okay? That's the difference between them. Now, in the paracortex, you'll start to have T cells, okay? Now, in the deep medulla over here, you will have other cells, such as macrophages, other T cells, eosinophils, a bunch of other cells. That's a key concept here. Now here, in a biopsy or in this histology, you'll have the cortex over here and the medulla inside. Very important is the cortex will have all of these follicles, secondary follicles in these cases, because of germinal centers. This is all uniform, meaning that the cortex will only have these follicles. The medulla and deeper structures will not have germinal centers. That's number one. Number two is it's not monoclonal. Being in monoclonal, it means that all the types of cells are one. This is not seen in normal lymph nodes. This is seen in abnormal lymph nodes. Okay, and I'll talk about this later. That's basically that. Now, in any case of a lymph node pathology, it can cause lymph node enlargement. Now, how do you want to manage a patient who has a lymph node enlargement? What do you want to do for them to diagnose what they have? Biopsy. lymph node biopsy is the gold standard of assessing a lymph node pathology. Okay. Now, in lymph node enlargement, there is, or lymphadenopathy, in basically in teenagers, patients under 30, it's usually in infectious causes, something benign. In elderly, or more basically above 30, it's usually danger sign. Okay. Usually it's most commonly infections. However, we can see malignancy, okay, which is either primary, which means lymphoma, or secondary, which means metastasis. Okay. Now, you have these two. And the first one is this patient, the first one. What do they have? They had an infection and they had lymph node enlargement, and then you see this under a microscope. What do they have? Follicular hyperplasia. Good. So basically, you'll have follicular hyperplasia. Very important thing that I wanted to mention for follicular hyperplasia, it's only in the cortex. The rest of the lymph node is normal. Okay. This hyperplasia is occurring only in the cortex. And you can see it's multiple colors. Why is it's polyclonal? Okay. Multiple colors, multiple types of cells here. It's all beta cells, however, there's a lot going on here. It's not one singular type of color cells. Okay. This is monoclonal, a sign of cancer. Here it's polyclonal. Okay. This is follicular hyperplasia, which occurs in infectious diseases. Okay, so anyone who has an infection, for example, strep throat or upper respiratory tract infection, it can go, for example, you might feel a swollen lymph node, and this is basically because of follicular hyperplasia. How about this patient? What do they have? It's in the medulla. Sinus histiocytosis. Good. Good. And here you have macrophages basically proliferating in the medulla or in the sinuses, which is because of infection. Same thing. Okay. Now, you have this teenager who's presenting to you with severe strep throat or severe pharyngitis, skin lesions, and very massive splenomegaly. What do you suspect they have? Mono. Good. Infectious mononucleosis. Perfect. So this is infectious mononucleosis. Good. What's the infectious organism typically causing infectious mononucleosis? EBV. Good. What's another one that may cause it? Rarely. Good. CMV. Perfect. Now, if you take a blood smear, what might you see? Blood smear. What type of cell would you see? Atypical lymphocytes. Good. Which is basically this. Very big lymphocyte. Very big cytoplasm. And this is typically CD8 lymphocytes. Okay. This is atypical lymphocyte. Mention the causes. You said it. Now, what specific laboratory findings would you see in acute setting of infectious mono? I want antibodies here. IgG, IgM, and early antigen. Good. This is the viral capsid antigen, IgM. It's very important to remember this is only elevated in acute settings. Then IgG will also be elevated, and early antigen will be elevated. Okay. Now, here are basically all the markers that you need to know. Early antigen, Epstein-Barr nuclear antigen. Then you have the viral capsid antigen, which is 2, IgG and IgM. If they have nothing, no infection, no immunity, all of it's going to be negative. Acute infection, you'll see, acute infection, ignore this one. Acute infection, you'll see positive viral capsid antigen, VCA IgM, VCA IgG, and negative Epstein-Barr nuclear antigen. This is elevated in chronic or previous infection, okay, or past infection. Tamam? Not chronic, sorry. Yeah, and that's basically that. In chronic, you'll have IgG will be elevated and the early antigen will be positive. Okay. Remember these different types of basically markers. When is it elevated? In acute, you'll see these two being elevated plus the early antigen. In chronic, you'll see this one, which is the IgG, and the early antigen, which negative EBNA IgG antibody. This is only elevated in past, infections. Okay, this is basically EBV. Now, EBV infectious mono will cause massive splenomegaly. So it's important for you to remember that in these patients, you basically tell them to do not play sports for around a month. The reason is because of the splenomegaly, even though they're treated for for the infectious mono, this splenomegaly will persist for 4 weeks. If they play sports and they get hit on the left side, this can cause splenic rupture and they die. Okay? This is basically the first concept in EBV. Okay. Now this patient has a cat and then presented to with an enlarged lymph node. What do they have? Cat scratch disease. Good. Okay. Toxoplasmosis will affect the brain. Okay, and other structures. So this is cat scratch disease, which is caused by what infectious organism? Do you guys know? Bartonella henlesei or henselae, whatever. Okay, so that's the infectious organism. It's caused by cat scratches, and the treatment is usually with antibiotics, erythromycin. That's all you need to remember. Okay, now there's one other type, which is, I don't have a slide for it. It's, he stressed on it a lot, which is Kikuchi's disease. Just remember it happens in females, and it's associated with autoimmune diseases, and it causes necrotizing lymph nodes. Okay, that's it. Now, very important, CD markers. Okay, so CD markers are important for you to differentiate different types of leukemias, or not leukemias, different types of lymphomas typically, okay, and specifically Hodgkin's and non-Hodgkin's lymphoma. So from 1 to 8, I just want you to remember T cells, okay? CD4, the T helper cells, we all know it. CD8 is the cytotoxic T cells, okay? That's basically that. All T cells will have CD3, all right? All T cells will have CD3, CD4 for helper T cells, CD8 is for cytotoxic. B cells will have CD10 to 23, okay? Obviously, we know that CD20, what's it called? Just remember, the CD10 all the way to CD23 is for B cells, okay? And specifically CD19 and CD20, because this is the usual one that you will be given, okay? Now, monocyte or macrophage, the most important one I want you to remember is CD15, and this is because it's positive for Reed-Sternberg cells. NK cell is not important. CD30 is important for this. Again, Reed-Sternberg. All leukocytes will have CD45, okay? These are the important ones that you have to memorize, and this is going to be tested in context of the type of cancer that you get, okay? And again, we'll go over all of these. Now, an important concept of a lot of leukemias and a lot of lymphomas is this, is the chromosome translocation. Now, to explain chromosome translocation, I want you to see this. Let's just say this orange part was over here, okay, and this green part was still over here. You have 2 chromosomes, and there's a part of the chromosome that's going to transfer to the other chromosome, and this will transfer to here. Now, what will this cause? Let's just say this chromosome, the orange part that was over here, encodes for let's just say, a cell cycle protein. For example, cyclin D1, okay? This protein will transfer to this green chromosome. What does this green chromosome have? It will have an enhancer. What does an enhancer do? It will cause overexpression of this gene, okay? When you have overexpression of something that's not supposed to be overexpressed, what will happen? Cancer, okay? What are the types of proteins that's going to be overexpressed in these types of cancers? Cell cycle proteins, anti-apoptotic proteins, or tyrosine kinase receptors, okay? 3 things. First, the tyrosine kinase, which will cause the cancers that we all know, CML, okay? And then you will have other types such as cyclin D1, BCL2, okay? BCL2 is basically an anti-apoptotic gene. If it gets transferred to a part that has an enhancer, this anti-apoptotic gene, BCL2, will be overexpressed. So that cell will no longer die, hence causing cancer. If it's cyclin D1 will keep the cell cycle going. If you have it being overexpressed, then that means the cell cycle won't stop, cancer. Is translocations clear? Cool. And we'll talk about it individually. Now, there is a set of mutations that I want you guys to remember. Firstly, CML will cause the BCR-ABL, and this has its own slide. But basically, a big part of translocations that occur is tyrosine kinases. Tyrosine kinase will basically cause the cell to proliferate, okay? Basically, that's it. BCR-ABL is one of those persistently active tyrosine kinases, which will cause CML. CMML, which is chronic myelomonocytic leukemia, will have TL, which is basically the thing that's being expressed. And this is the tyrosine kinase, which is a growth factor receptor, which is platelet-derived growth factor receptor, the NOR beta. Okay, this is the tyrosine kinase. It's going to be overexpressing TEL, which is going to cause this cancer. Same thing here, it causes eosinophilic leukemia, whatever. Then this one, and this one is and obviously this one, we'll talk about it, are the main important ones that I want you to remember. CML, obviously the Philadelphia chromosome. Systemic mastocytosis is c-KIT positive, okay, which is also tyrosine kinase, so it will keep on activating and cause expression of a lot of monocytes, okay? Or in other words, macrophages. Here, you'll have RBCs, which if they're overexpressed because of a JAK2 or JAK kinase receptor, it will cause polycythemia vera, okay? An essential thrombocythemia, I think that's what this one is basically a platelet one, again, JAK2. What I want to remember, polycythemia, systemic mastocytosis, and CML. The main gist of this entire slide is a tyrosine kinase is causing the cancer. Okay? That's basically this. Now, in leukemias, I just want you to remember this before we go into all the types of cancers. Is you have two types, acute, chronic. And then depending on what type of cell is being affected, if it's lymphoid derivative or myeloid derivative, that's it. In acute, it's rapid onset. And the key term I want you to remember is blasts, okay? If it's more than 20% blast, it's acute. If it's less than 10%, it's chronic. If it's between them, then this is, I think, what is called progressive, okay? So that's basically the gist of this, okay? In acute, it's usually rapid onset. They will get very sick very fast, have pants or basically non-functioning cells, basically. And yeah, it's very bad. In chronic, it's typically indolent and it's a long-term chronic condition, okay? So that's basically how to differentiate what does acute mean, what does chronic mean, okay? Now we go into, firstly, the lymphomas. Firstly, what do you see in this image? Reed-Sternberg cells. So what type of cancer can you see here? Hodgkin's lymphoma. Good. Okay, perfect. So this is Reed-Sternberg cell, which is Hodgkin lymphoma. What are the CD markers that are positive for Reed-Sternberg cells? 15 and 13. Excellent. Now, which subtype of a Hodgkin lymphoma has many Reed-Sternberg cells? Many. And it's the worst type of Hodgkin lymphoma. Lymphocyte depleted. Good. Okay. So basically, in Hodgkin's lymphoma, how will the patient present? With B symptoms. So they have, for example, fevers, night sweats, chills, weight loss, and then they'll have a swelled lymph node. Okay. These are B cells, or B symptoms, sorry. The key gist of what Reed-Sternberg cells are is more Reed-Sternberg cells, more cancerous this tumor is, okay? The worse prognosis it is. Less Reed-Sternberg cell, the better, okay? So this is the Reed-Sternberg cell, the two-eyed cell, okay? And then you'll have a bunch of lymphocytes around it. The cause of the symptoms are B symptoms, which is basically cytokines being dumped into the blood vessels or into the bloodstream, and then this causes all the fever, weight loss, night sweats, night chills, and so on. Okay, that's basically in Hodgkin's lymphoma. A Hodgkin's lymphoma has 4 types, which are these. The first type, which is the most common type, is nodular sclerosis. The main important thing is it's most seen in female, the most common type, and you'll have fibrosis happening in the lymphocytes, in the lymph nodes, sorry. And this one is a good prognosis, okay? And we'll look into pictures of this. Mixed cellularity has many different types of cells. It's more frequent in elderly, and it's okay in terms of prognosis. Now, this too depends on the amount of Reed-Sternberg cells. If it has few, that means it's lymphocyte predominant, it's good. If it has many Reed-Sternberg, such as lymphocyte depleted, poor. Is this clear? Okay. So now we'll go into the pictures. What is this type of Hodgkin lymphoma? Perfect. Nodular sclerosis, which we'll see bands of fibrosis. Fibrosis is what? Pink. You see this fibrosis happening here? All this is fibrosis. And it can cause nodularity in the lymph nodes. Okay? This is nodular sclerosis. The most frequent type has a good prognosis and mostly seen in females. These are the key words to remember. Okay? Nodular sclerosis. This one has many different types of cells. So what do we call this? You can see, for example, lymphocytes, some RBCs, eosinophils here, and then Reed-Sternberg cells. So you have mixed cellularity, okay? Now, this type is what? It has 2 forms, one in the lymph node and one in the bloodstream. That's your hint. Small lymphocytic lymphoma or chronic lymphocytic leukemia. Good. SLL or CLL. What age group is affected? And in all of these lymphomas, I want you to remember age group, type of cell, marker, and if there's a translocation as well. Okay. Age group is an elderly. What type of cells are affected here? B cells. What is the size? And the size as well. It's from the name, small. And then what markers are positive? It's a Hodgkin lymphoma, or it's a lymphoma, so, and not Hodgkin, sorry. CD20 and CD5. Good. So this is marker for B cell. CD5 is not a marker of B cells, right? It's a marker of T cells. However, this is the unusual part of it, is this marker will be elevated in CLL, okay? Now, CLL can present also in bloodstream, right? And it's the name. So what do you see here in this image? This is chronic lymphocytic leukemia, okay? This is CLL. You can see these types of cells, which are smudge cells. Good, okay? They're basically, these 2 diseases are the exact same. If you get a question on CLL, it's going to be the same as small lymphocytic lymphoma. Just remember all of these markers, and it's TDT positive because it's a lymphocytic derivative. And in the blood, you can see smudge cells, okay? That's basically CLL. What is this one? This is the part where I ask you guys a lot of questions because it's memorization based. There's no like understanding. Oh, one thing is CLL and SLL can turn into this, which is diffuse large B-cell lymphoma, okay? This is the most common non-Hodgkin's lymphoma, okay? Most common. So now, what age group is affected in diffuse large B-cell lymphoma? Everyone, good. What type of cells? From the name. B. What is the size from the name? Large. And then what markers are positive? 19 and 20, which are B markers, okay? Now, Do you guys know what is it called when an SLL, small lymphocytic lymphoma, or a chronic lymphocytic leukemia turns into large B-cell lymphoma? Do you know what that thing is called? It can transformation, yes, Richter's transformation. Basically, CLL is one of the most common types of leukemias. It's usually asymptomatic. Patients will usually won't have symptoms. And the fear complication of it is it turns into this, okay, through Richter's transformation, okay? So this one, again, most common cause, affects all ages. The type of cells is large B cells, and the markers that are positive are CD20 and CD19, okay? In the histology, they're just very large, ugly cells. That's basically that. Now you have this patient who is not symptomatic, but has a very large lymph node. This is follicular lymphoma. Good. What age group is affected? For the symptoms of follicular lymphoma, all I want you to remember is it's indolent. They commonly describe it as waxing and waning. Okay, so in a scenario, you might get a patient who's completely asymptomatic, has a swollen lymph node, and then you test it and you see this. Okay, so what age group is affected? Elderly. What type of cell? B. Translocation. This is high yield. What type of translocation is happening here? 14 and 18. So chromosome 14 has something which is causing overexpression. Okay, chromosome 14, just so you guys know, has the Ig heavy chain. If you remember from an antibody, excellent. The antibody has a heavy chain which is overly expressed. This 18 has what? Do you guys know? Someone already mentioned it. BCL2. Good. BCL2 is an anti-apoptotic gene. So when an anti-apoptotic gene goes to the chromosome 14, which has the heavy chain, this will be overexpressed, not causing apoptosis. Hence, in follicular lymphoma, you will not have dying B cells. Okay, that's basically that. What markers are positive here? 10, 19, 20, and then you already mentioned BCL2 and 6. Okay, 10, 19, 20, BCL2 and 6. Remember these translocations, remember these markers. Okay, you will 100% get these in the exam. Again, follicular lymphoma, it's usually indolent, meaning that it doesn't usually cause a lot of symptoms acutely. It's over time can cause symptoms. Usually a patient will not have anything, will be described as normal, and then has a swollen lymph node, and then you'll see this picture. Okay, or will tell you that they have a translocation 14-18. Okay, and then you know what it is. It's follicular lymphoma. Okay, and you know the markers that are positive, or they'll give you these markers and they'll ask you about the translocation. Okay, that's basically this. Now you have this, which is a very aggressive one. The patient is going to get sick very fast. No. Mantle cell, good. Okay, mantle cell lymphoma. What age group? Adult, good. Adult males, perfect. What type of cells? B cells, good. Translocation, 11, 14. Again, 14 has a heavy chain. What does 11 has? Cyclin D1, which is in the cell cycle. So you'll have the cell cycle keep going and going and going, hence cancer. Okay, mantle cell lymphoma, what markers are positive? CD5 and 20, good. Again, cyclin D1. Okay, remember this one. Again, in B cells, you're not supposed to have CD5. If it's there, then it's abnormal, hence cancer. Okay, so that's basically mantle cell. Now, you have a child who comes from Africa. has a very enlarged jaw? Burkitt's lymphoma. What do you see on this image? Starry sky appearance. Remember this image. Okay. Starry sky appearance. It's basically Burkitt's lymphoma. Okay. Which is all these. There's a specific name for these macrophages. I forgot what it was. Anyways, but basically these are macrophages. Okay. This is Burkitt's lymphoma, starry sky appearance. Okay. What age group is affected? I gave you a hint. Tingible body macrophages. Excellent. Good. Tingible body macrophages. Good. Of children. Okay. What type of cells? B, translocation. 814. What's on 8? c-Myc, which is a proto-oncogene expression. Okay. And then markers, it's pretty much the same. What markers are positive? (1920) c-Myc plus CD10. Okay. Because they're B cells. Tamam. Now, is there an infectious organism that is associated with Burkitt's? EBV. Good. Now, EBV, the most common example in a case is usually an African child with a very big jaw. This is characteristic for Burkitt's lymphoma. And the last group for the translocation, which is 814, which is for BCL6, and this is c-Myc as well. Okay. What else? There's also another form, which is a sporadic form, which is usually presenting as an abdominal mass. So anyways, whatever. This is basically Burkitt's lymphoma. Now you have a lesion in the skin. This is a type of, yes, mycosis. Good. This is called mycosis fungoides. Okay. What type of cell is it? What type of cells? B or T? Just give me this. T cells. Good. This is a T cell, the non-Hodgkin's lymphoma. If it's in the skin, it's called mycosis fungoides, which causes this microabscess or the Partier's microabscess or whatever it's called. If it's in the blood, it's Sézary syndrome. Okay, that's all you need to know. Tamam. This one. Anaplastic. Good. Which is large cell lymphoma. What age group? This one is just you need to know just the image. Salaha. I don't think you'll get asked MCQ. I don't think this know it. What age group? Oh, good. What type of cell? T. Translocation. 2 and 5. Good. And then what markers for T cells? 30. Yeah. T cell markers, ALK, which is, yeah, and then CD30. Good. Tamam. This is, I think you might get it, and you get this in the question. Okay, they'll give it to you. Okay, and then you just guess either translocation or the anaplastic large cell lymphoma. Usually the lymphoma questions are very straightforward. Okay, it's very, very straightforward. It's either match, for example, the tumor with the marker, or they'll give you the markers in the question and you just diagnose the tumor. Okay, it's straight memorization. That's why I'm not explaining much, because there isn't much to explain rather than the translocations and how it happens and the symptoms. But usually these are bad. This one, especially anything that has anaplastic, is just a bad tumor. Okay. Now this one. I'll give you a hint. It's a teenager with a mass right here in the mediastinum. I'll give you a hint. This is a thymus. Lymphoblastic lymphoma or lymphocytic leukemia or whatever, which is ALL. Okay. This is typically how ALL presents, which is basically what this is, okay? There's overlap between lymphoma and leukemia because it affects the thymus. What age group? Children. Type of cells? What does the thymus has? T cells. Good. Or it's B cells. It can happen if it's ALL other type, but usually it's T cells. Size? Give it 2 because, yeah, it's intermediate. Markers. If it's T cell, what markers are positive? 2, 3, 99. Good. What if it's B cells? 90, 20. Good. And TTT positive because it's lymphocytic, or yeah, lymphocytes. Good. Perfect. Okay. Now, as I said, this is usually described as acute lymphocytic leukemia or acute lymphoblastic leukemia. And it's typically a T cell. It can be B cell. And the way I remember ALL, teenager, thymus, T cell. Okay. The 3 T's. Thymus as a mediastinal mass. Okay. It'll present as a mediastinal mass in a teenager. You think of ALL immediately. Okay. And it's one of the more common ones in children. The rest of the leukemias, no, this is not the one with our rods, a different one. Yeah, it's not the one. Again, in children, usually it's ALL, okay? The other types are usually in elderly, okay? Such as CLL that we already saw. This one is what? We just described it, not multiple, I know. ALL, good. Acute lymphoblastic leukemia, I already gave you most of this. Now, since it's acute, what is the blast percentage? It's acute. More than 20, good. Now, this was given to us by Dr. Rayhan. So there's 2 types of translocations. Good. The translocation that has a good prognosis is 1221. Remember this one. There's one that has a bad bad one or bad prognosis, which is 922, which is the Philadelphia chromosome. Good. Perfect. Again, ALL, usually in children, mediastinal mass is a typical finding, can have T cell or B cell. Okay, the way I want to remember it is T cell because it's TTT. Thymic mass, and then you'll have, for example, blast percentage over 20, translocation with good prognosis. Remember this translocation is 1221. Just replace it with each other, 12, just replace the numbers, 21. And then 922, which is a very bad, obviously we know this, bad translocation, which is the Philadelphia translocation, okay? Now you have this with an hour rod. What is this? AML, good. Acute myeloid leukemia, good. Age group, I gave you this. The only one that usually presents in children is ALL, so this one will present in elderly. Adults, blast percentage is acute, so more than 20. 2 features in this image. This is very high yield. Hour rods, and one more, if you can guess. Granules, cytoplasmic granules. Excellent, good. Good. Now, AML, since it's myeloid, what marker could be positive since it's a myeloid cell? Do you guys know? Myeloperoxidase, excellent. So myeloperoxidase will be positive since it's a myeloid lineage cell, okay? Myeloperoxidase is what's causing all these granules here, okay? Now, one very high yield, commonly tested subtype of AML is this one, with many hour rods, which is a PML, acute promyelocytic leukemia, okay? Very important is you know the translocation and how to manage this patient. So the translocation is 1517, affecting what exactly? All trans-retinoic acid. Perfect. Perfect. Okay, it's a PML RAR alpha mutation. The 2 features is Choroidocytes with our rods. Treatment is all transtretinoic acid. I was just going to mention what's a complication, and you mentioned it already, DIC. Okay, this can lead to DIC as a complication. Okay, now, what is this? Myelodysplastic syndrome. Good. Now, for myelodysplastic syndrome, I just want you to remember specifically just the images. I don't want you to remember anything. Like, other than that, it's a very confusing topic, especially to me. I find it very confusing, but just remember, what do you see here? Ring sideroblast. These two images will 100% come. Okay? Obviously, all the rest, especially this one, will come, but this one will most likely come as an OSPE. Okay? This image, which shows you multiple lineages that are affected, okay? And then this one, you will have ring sideroblast, okay? Now, you have this patient who has elevated WBCs, including basophils, CML, chronic myeloid leukemia. But translocation, the high yield translocation, what is it? 922, which is what? Philadelphia chromosome. Good. This image, you'll see what? Immature neutrophilia, you'll see basophils and all that stuff. Ignore this question. Lab findings, as I said, this is very high yield. What lab findings will you see? Lymphocytosis and basophilia. Okay, good. There are 3 phases for CML. What are the phases? Chronic, accelerated, and blast phase. Good. Perfect. If it's blast, what's the percentage of blast cell? More than what? We keep mentioning it. 20. What is, if it's below, what number is chronic? 10. Between them is accelerated. Clear? Is there a drug we can give here? Specific drug? Imatinib, which inhibits what? Tyrosine kinase. Right. Now, there's a very confusing part of CML, which is comparing it to leukemoid reaction. Leukemoid reaction, you will see very high lymphocyte count, specifically neutrophils, above 50,000. You will also see a lot of neutrophils here as well. Now, how do you differentiate it? This, because what this is basically leukocyte alkaline phosphatase. Okay, this is elevated in leukemoid reaction. This is 100% coming. Okay, you'll see elevated leukocyte phosphatase in leukemoid reaction, and it's negative or decrease in CML. What will you also see in CML? BCR-ABL positive, and you'll have basophilia. Okay, so now can you differentiate the two? It's just one lab, it's just lab values. That's it. And usually leukemoid reaction is due to some sort of infection that's happening with the patient. Very severe infection. Do you differentiate it by leukocyte alkaline phosphatase, basophilia, and the presence of the chromosome translocation, the Philadelphia chromosome? Clear? Okay. This is basically the Philadelphia chromosome. I explained the concept of the translocations. But basically, BCR gene is on the chromosome 22. You'll have the ABL gene that goes to the BCR gene and forming the 922 chromosome translocation, which is a tyrosine kinase, and it'll keep on proliferating the cell. Okay? You manage CML by inhibiting this tyrosine kinase using imatinib. Okay? Now we're done with the lymphomas, leukemias, and all that stuff. Now we go into other basically myeloproliferative diseases. You have this patient who's coming to you with severe pruritus, severe itchiness that happens with showers. and this facial plethora. What is it? Polycythemia vera. Good. Now, polycythemia, you will have elevated RBCs. That's basically the pathology, is RBCs will be very elevated. The reason why they're elevated is important to remember. In the context of your exam and your block, you need to remember the primary cause of PCV, of polycythemia vera. There are secondary causes, which is, for example, if a patient is in high altitude or something, and they need to produce more RBCs, they will have polycythemia. Or if they have, for example, something called sleep apnea, they will have polycythemia because of erythropoietin. In the case of hypoxia will lead to polycythemia. In your block, primary polycythemia, which is the genetic one, is due to what mutation? JAK2. Good. Okay. JAK2, which can be easily treated. How do you treat polycythemia vera? What drug can you give? Which inhibits JAK kinase? Ruxolitinib. Good. Okay. So how do you diagnose polycythemia vera? High hematocrit, bone marrow, which shows you hypercellularity and the presence of this JAK2 kinase receptor. Okay. Now, these patients, as I mentioned, will come to you. The very key characteristic finding, which will always be mentioned, is you will have severe pruritus when you take a shower. This is a very, 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 very important feature of polycythemia vera. Other than that, it can cause facial plethora, okay, which basically means the face will be very red and filled with blood, okay, which is what's seen here. It's very red, okay. And obviously hematocrit will be very high hemoglobin, and then you'll have JAK2 receptor mutation, okay. This is polycythemia vera in a nutshell. Now, you have this patient who has splenomegaly and will have these findings. You do bone marrow biopsy and you see this. And you do peripheral blood smear and you'll see this. This is what we call myelofibrosis. Good. So in myelofibrosis, you will have very low blood cell count because in the bone marrow, the cells, the bone marrow will be very fibrosed. So even the red blood cells that are being synthesized will have to go through and squeeze themselves through the bone marrow, which will form these cells, which is what type of cell do we call this? Or what do we call it? Teardrop cell or dacrocyte, okay? This is myelofibrosis. Now, you have this patient who's coming to you, an elderly, who's coming to you with renal failure, very severe back pain. Multiple myeloma. Good. So multiple myeloma is basically a cancer of basically of plasma cells, okay? Now, typically, this causes an elevation of a single type of antibody, usually IgG, then IgM, okay? Usually, most commonly is IgG. Now, this multiple myeloma will cause plasma cell proliferation. That's number one. Number two is it can cause lytic lesions in the bone, okay? Now, this lytic lesions in the bone will firstly cause hypercalcemia, okay? Because bone, when it's getting basically broken down, it releases calcium into blood. So you have hypercalcemia. This calcium will go all the way to the kidney and damage it. Renal failure, okay? And another thing is in multiple myeloma, there's something called Bence-Jones, I think. It basically goes and deposits in the kidney, causes renal failure. So it commonly manifests as something called CRAP, which is hypercalcemia, renal failure, anemia because of the cancer, and it will cause back pain and bone lytic lesions. So you have these lesions in the skull, for example, where it will be lytic. The bone is being destroyed, basically, and it causes this lysis or lytic lesions. Okay? What do you see in this image? clumping, which is what do we call? Rouleau formation. Good. Okay. Here you can see plasma cells, and then here lytic lesions. Okay. This is very important. How do you want to diagnose this patient with multiple myeloma? First, you do labs and everything. Then what is one test? Urine. What do you want to look in the urine? IgG. Okay. The M protein. Basically, you look into the spike, the IgG M protein spike. This spike is because there will be one type of antibody that will be spiked up, okay, because it's basically one type of antibody that's being produced because of this plasma cell cancer, and it's usually the M protein type, which is encoding for IgG, okay? That's basically the monoclonal protein elevation, okay? Now there's diagnostic criteria for multiple myelomas. You need to see obviously the CRAB feature, hypercalcemia, renal disease, anemia, plus the bone lytic lesions. That's number one. Number two is you see this M protein spike, which is very diagnostic and very important to remember. And then if you take a bone marrow biopsy, you'll see monoclonal plasma cells above 10%. Okay, this is basically for multiple myeloma. Now, there is a CD marker that's also in multiple myeloma. Do you guys know what it is? It's very low yield, just in case, is CD138. Okay, in case it comes. CD138. Okay, this is basically multiple myeloma in a nutshell. Now, we're almost done with onco, and then micro will be very easy. So for chemotherapy, each type of cancer has its own drug regimen. Okay, that's number one concept that I want you to remember. So in chemotherapy, in ALL, it's basically a regimen of two courses, course A and course B, and this is what we give in induction and maintenance. This is what we call the hyper-CVAD, okay? Now, induction, you do it with multiple agents such as vincristine, whatever, prednisone steroids, cyclophosphamide, doxorubicin, asparaginase, whatever. You induce the chemotherapy for induction, first chemotherapy. Then you add the consolidation, which is given right after induction, which is with hyper-CVAD, which is cyclophosphamide, vincristine. I'll go over each of these drugs, don't worry. Adriamycin, dexamethasone. Then you maintain it, which is with methotrexate, steroids, and vincristine, which 6-mercaptopurine. Anyways, what you want to remember is just each of these drugs, what it does and the side effects. That's it, okay? This whole thing, don't worry. But if you get a question for ALL, just remember hyper-CVAD, cyclophosphamide, vincristine, adriamycin, dexamethasone. Remember these four. Now, basically in the treatment of ALL, it's two courses, course A and course B. You give, for example, course A for a month, then you switch to course B, and you keep switching between them. This will basically increase the efficacy of the chemotherapy. The first one is asparaginase. There's not much to remember about it in terms of what it does, so don't worry. Then we have cyclophosphamide, which is a prodrug, which basically gets broken down to phosphoramide mustard. It causes cross-linking. What's important about cyclophosphamide is that it can cause hemorrhagic cystitis. How do you prevent hemorrhagic cystitis? Two ways. How? Number one is hydration. Number two is mesna. Good. So that's basically that for cyclophosphamide. Again, the main thing about this lecture is just know the side effects and know the mechanism of action. That's all you need, okay? The key side effects I will mention to you. Cyclophosphamide cross-linking and causes apoptosis as well, and it causes hemorrhagic cystitis. This is a very high yield, commonly tested side effect. Methotrexate, we know it causes, blocks basically dihydrofolate reductase, and the side effect, it causes myelosuppression, it causes liver and GI side effects as well, okay? And obviously, In this case, it basically causes depletion of folic acid. So you give folinic acid, which bypasses this step. Okay. So that's basically that. The ensitarabine, which basically inhibits the DNA polymerase. The most important side effect to remember is ataxia. Okay. Another one is keratitis. Okay, which is basically corneal toxicity in the eye, so causes blurry vision and vision loss. Okay. Now, in AML, you give combination therapy, which is basically the cytarabine and doxorubicin or daunorubicin. Daunorubicin, very important to remember, is a serious side effect, which is cardiotoxicity. Okay, remember cardiotoxicity. Etoposide inhibits topoisomerase 2, which causes a bunch of side effects such as GI irritation, bone marrow suppression, which is a common chemotherapy side effect. Okay. Now, for CLL, you have usually, again, it's asymptomatic patients. You just observe them, as I mentioned. It's the most common adult type of leukemia. Now, you can give their specific drug, which is this one, okay? And just memorize this for CLL. Okay, there's not much to this. Now, the one I really want you to remember is CML. Okay, CML, the best way to treat it is tyrosine kinase inhibitors. That's the main thing. You start off with imatinib, and if it doesn't work, then you go to these other tyrosine kinase inhibitors. The side effects, it can cause congestive heart failure, nausea, vomiting, and other stuff. And other side effects is myelosuppression, hepatotoxicity, headaches, and so on. Okay, again, just remember this table and which agents will cause what specific side effect. So, for example, thromboembolic events, ponatinib. Okay, congestive heart failure, nausea, vomiting, especially congestive heart failure, imatinib, and then the rest is for nilotinib. Again, I'm speeding through this because it's just pattern recognition. There's not much for me to explain here. Lastly, for Hodgkin's lymphoma, you give ABVD chemotherapy, which is adriamycin, doxorubicin, or doxorubicin, bleomycin, which is this one, and vinblastine and dacarbazine. Now, for this one, it induces apoptosis, and it can commonly cause pulmonary toxicity. This is the most important side effect, and you treat it with corticosteroid. That's pretty much that. Okay. Now, what is one feared complication of chemotherapy typically is when you kill cells too fast. Okay? When you kill cells too fast, you can cause something called tumor lysis syndrome. Now, tumor lysis syndrome causes multiple things. Now, inside of cells, you need to remember that you have a lot of potassium and you have a lot of phosphate. Okay? So what will potassium do first? Because you're killing cells very fast, potassium will go into the bloodstream. This hyperkalemia, the most important effect of hyperkalemia is in the heart. It can cause arrhythmias. Okay? This can cause, for example, long QT syndrome, and this can cause Trossard's DuPont's when we just finished CVP. This is hyperkalemia, very bad arrhythmias. Okay? And obviously, Trossard's can lead to VFib. Then you have hyperphosphatemia. The bad thing about hyperphosphatemia is two things. Number one, can cause hypocalcemia. Why so? Its phosphate will bind to calcium in the blood and will cause hypocalcemia, which can cause arrhythmias. Number two is it can cause calcium phosphate deposition in the kidney, okay, causing acute renal failure. Now, one other thing is in these cells, you'll have increased catabolism of the cells, including purines, DNA. Purine catabolism, the end pathway is uric acid. So you'll have hyperuricemia, which can cause gout, okay? And uric acid deposition in the kidney causing acute renal failure, okay? This is hyperuricemia. Tamam? So again, in a nutshell, what are findings of tumor lysis? This is very important. Hyperkalemia, hypocalcemia, hyperphosphatemia, and hyperuricemia. These four, okay? How do you treat? The main thing for prevention, the main thing to remember about tumor lysis is how do you prevent it and treat it is hydration. Give the patient a lot of fluids while you're giving chemotherapy. Okay, this is the main way to prevent and treat tumor lysis syndrome. If they present with these complications, give a lot of IV fluids, and then treat the underlying cause. If they have hyperkalemia, you treat hyperkalemia. If they have hyperuricemia, you give one of two drugs, allopurinol or pegloticase, okay? And then if they have hyperphosphatemia, you treat it as well, okay? You don't need to know the drugs for these two. Just remember, in the case of tumor lysis syndrome, you treat it by fluid hydration, and you treat the hyperuricemia with allopurinol or pegloticase. Is this clear? Because we are done with onco. Is there anything you'd like me to mention for oncology or any of those topics that we covered, or is everything clear? So now we'll go into the last part, which is micro, which will deal with two major diseases and then some random ones that are in your lectures. Now, the first one is HIV. Okay, HIV is very confusing, صراحة, but I'll try my best to explain how HIV works and how to treat it. So HIV, obviously, it's a virus and it causes severe immunodeficiency. Specifically, it targets T cells. Okay, so it causes T cell depletion, specifically T helper cells, CD4 T helper cells. If you have CD4 T helper cells are decreased, this will cause other cells to be affected, because why? This is the main cell that will basically release cytokines to activate other lymphocytes. Okay, so HIV, the structure of HIV is crucial to remember. Why is it crucial? Is because of the medications that we give to treat HIV. They have three specific structural genes: envelope, gag, and pole. Okay, the envelope genes, there's two, GP120 and GP41. Okay, now GP41 and GP120 are involved in the entry of the HIV into the cell. Okay, GP41 binds to CCR5, and then GP120 will allow it to enter. Okay, basically that's that. Then you have GAG protein, which is the capsid and matrix protein. Not really important. This is very important. The pole gene is responsible for reverse transcriptase, integrase, and protease. What are these proteins, basically, or enzymes? Reverse transcriptase will take the mRNA and convert it back to a DNA. Why is this important? It's for integration into the host DNA. How does it integrate into host DNA? Through integrase. Then afterwards, it basically, once it integrates into the host DNA, you'll start to have transcription, translation of new viral virions, okay, which basically will be released from the cell and infect other cells. That's how HIV spreads. How does it be released from the cell? Through protease. Okay, I'll explain this in this figure. Again, you will have this. Firstly, is you need attachment, which is through GP120 and GP41. GP41 will bind to CCR5, GP120 will bind to CD4. Then you'll have entrance. How can you inhibit this? You inhibit CCR5, or you inhibit the fusion itself, which is through GP120. Okay, you inhibit one of these. You go into the cell. HIV is now into the cell. What does it need to do? It needs to undergo reverse transcription through reverse transcriptase. So what does HIV need? Reverse transcriptase. So what can you do to inhibit reverse transcriptase? Either nucleotide reverse transcriptase or non-nucleotide RTIs, which is non-nucleotide reverse transcriptase. NRTI basically binds to the HIV binding site of reverse transcriptase, and RTI binds somewhere else on the reverse transcriptase, which inhibits it. Okay, that's basically this class of medications. Then, okay, let's just say we didn't give a medication yet. The patient has HIV. Okay, now they have the reverse transcriptions, which is transcription that happened. They have the DNA now. The DNA will now try to enter the host DNA. Okay, and they do this through the enzyme integrase. How do you inhibit this? Integrase inhibitors. Okay, let's just say it moved on. It integrated into the patient's DNA. Through transcription translation, it will produce new virions that wants to be released into the outer cell, and new viruses can now affect other cells. How do you affect this part, which is the release from the cell? Through proteases. Does the HIV structure and pathway make sense to you guys? Yes or no? Because if you understand this pathway, you understand how to treat it. Good. The management, you either inhibit the fusion through two mechanisms, CCR5 or fusion inhibitors. You inhibit the reverse transcription, which is the key way we treat it anyways. You inhibit integrase or you inhibit protease. Okay? Now we'll go over these medications. Now, when do you give these antiretrovirals or medications to patients with HIV? Is you give it when they are diagnosed, immediately. Once they are diagnosed, you give them immediately. Now, usually, we give 3 drugs to prevent HIV resistance. The 2 drugs are 2 nucleotide reverse transcriptase or nucleoside reverse transcriptase and an integrase inhibitor, usually. Okay? So the nucleoside reverse transcriptase, again, they competitively inhibit the nucleotide binding to the reverse transcriptase, as I mentioned. There are multiple ones. You have abacavir, emtricitabine, lamivudine, tenofovir, zidovudine. This one will come later in another block as well in the hepatitis drugs. But anyways, you have all of these. The very important things, as I want you to remember, is the side effects of these drugs. Firstly, the nucleoside reverse transcriptase, how it works, it inhibits the reverse transcription. So that way, it will not integrate itself into, it will not basically, the RNA will not turn into DNA, okay? So you will not have integrase later on. Now, zidovudine, very important, is it can be used in pregnancy. That's number 1, like fun fact number 1. All of these drugs can cause myelosuppression, nephrotoxicity. Abacavir is contraindicated if a patient has this HLA-B5701 mutation. This will come in the exam. Okay? Abacavir is contraindicated if they have this mutation. Now, non-nucleotide or nucleoside reverse transcriptase inhibitors are these medications, these 3. They bind to the reverse transcriptase as a different site, okay? And basically, they can cause rash, hepatotoxicity, and efavirenz has these specific side effects, which is vivid dream and CNS symptoms. Now, you specifically give these 2 medications, or 2 of these, and 1 of this, which is an integrase inhibitor, which is, it has Tegra in the medication name. So if it has Tegra in the name, you know this is an integrase inhibitor, okay? So that's basically that, and you know how it works. It inhibits HIV genome integration into the host cell gene, okay? Now, protease inhibitors ends with Nevir, okay, so just remember that, and it basically prevents the new virions, new viruses being released, okay? That's basically that. And then you have 4 of these drugs, and just to remember, it can cause hyperglycemia, GI intolerance, and yeah, that's basically that, the fun facts to know. Now, the entry inhibitors, which is for the fusion, which is either binding GP41 or binding CCR5. Okay, one of these 2. And enfuvirtide binds to GP41. Maraviroc inhibits CCR5, which binds to GP120 for the attachment. Okay. These are basically HIV drugs and the, what's it called? The HIV cycle and structure. Is everything clear for HIV? Again, for HIV, it causes very severe immunodeficiency, which causes like the CD marker, CD4 T cells will be very low. What's a very feared complication of HIV is number 1, AIDS. Number 2, opportunistic infections, such as, I don't know if you guys need to know this, I doubt it, but for example, very severe fungal infections. I'll give you that, okay? If you remember from CVP, pneumocystis jirovecii, that's one of them. Is it clear, HIV, or do you want me to repeat something? تمام. Okay. Now, what we know is malaria. Malaria, what's the mosquito associated with malaria? Anopheles mosquito. Okay. Female Anopheles mosquito. It comes for a blood meal, or basically, yeah, it comes to take blood, and it basically puts sporozoites into the blood. Now, for all types of Plasmodium species, which is Plasmodium falciparum, vivax, ovale, malaria, no lesse, it goes and affects RBCs. Skip this for now. It goes and affects RBCs. Now, RBCs will have the trophozoite will start growing and form into a schizont. This schizont is a bag of trophozoites at this point. It'll keep growing until this RBC no longer can hold these schizonts. Or this schizont no longer can hold the trophozoites. And it releases something called merozoites. What will this merozoites do? Go and infect other RBCs. And it causes a vicious cycle. When these RBCs lyse and release the schizonts lyse and release the merozoites, it causes the symptoms of malaria, which is hemolysis, hemolytic anemia, jaundice, severe anemia, and so on. And it can cause something called black water fever if it's very, very severe. Okay? Now, this also early trophozoite form can form into gametocytes, which is basically for the sexual reproduction of malaria, which when another mosquito comes and takes it, it basically will go from a gametocyte back to a sporozoite inside the mosquito. Now, for two specific types of Plasmodium species, you will have dormant forms. This is high yield. What are the two types of Plasmodium species that can lay dormant in the liver? Vivax ovale, good. So these sporozoites can go into hepatocytes and form a hypnozoite, which is the dormant form of Vivax and ovale. This is the life cycle. Now, to diagnose, one of the ways we can diagnose is to take blood smears. So you'll see here what type of blood smear you have. You have two types. This one is what type? This type is thick. Thick film will basically allow you to detect the presence of malaria. That's it. It will tell you whether or not there is malaria. And you can see some trophozoites here, okay? Which is the headphone sign, okay? If you want to identify the actual species of malaria or the actual type of malaria, you need to do what? Thin smear. Good. Good. Now we'll start take. This is a thin smear. What type of Plasmodium is this? Good. Now, Plasmodium falciparum is the one that usually causes the most severe type of malaria. What type of fever is seen in Plasmodium falciparum? You have black water fever. I meant the cycle of fever. Tertian malignant fever or irregular. Okay? Tertian malignant fever in Plasmodium falciparum. This is the one that causes the more severe symptoms. Now here you have what in the RBC? Rings, or the trophozoite, the ring-shaped trophozoite, or the headphone sign, okay? This is another one of the rings. What is this gametocyte, which looks like what? Banana, okay? Banana-shaped gametocyte. Very characteristic for Plasmodium falciparum. Good. How about this one? I should say a patient keeps getting cycles of malaria because it's in the liver. Vivax, okay? This is Plasmodium vivax. It looks like a more disrupted feature of falciparum, and so you can see a ring, but it's a pretty distorted ring. Anyways, Plasmodium vivax, what type of fever is seen here? The cycle. Tertian, but not malignant. Not quaternary is something else. Tertian, but not malignant, okay? Very high yield fact about this is it lays dormant in the liver. Do not forget that fact, okay? This one looks like an oval shape, so what is it? Ovale, good. Again, what type of fever? Tertian, not malignant. Number two is dormant in the liver. Okay, I will keep repeating that because it's a very important concept. Now, how about this? Very organized, parallel lines. What type of it? Malaria. What type of fever is seen here? Yes. Quartan fever, which is every 4 days. The other one was every 3 days. Okay, tertian is every 3 days. How about this one? I honestly don't know how to describe it, so I just hope you guys can get the picture. No lesse, which in the slide had a monkey, and I don't know what it means. Okay, so Plasmodium no lesse. Now, oh, the intermediate host. I did not know that, not gonna lie. So yeah, the monkey is an intermediate host. Now, the important thing about malaria is to know what medications to give. Okay, so if a patient is gonna go, asymptomatic patient does not have malaria, but is gonna go to Africa. Okay, what medications would you want to give in a chloroquine non-resistant area? From the name, chloroquine or hydroxychloroquine. If it's a chloroquine resistant area, you want to give quinine. Okay, that's the basic thing to give. Now, for the chloroquine and hydroxychloroquine, basically what it does is it basically inhibits heme polymerization to hemazine. Heme is a very toxic structure to Plasmodium, okay, species, to malaria. When this happens, it causes basically lysis of Plasmodium, okay? Now, what will it do in terms of side effects? It's very important. Is GI, irreversible bilateral retinopathy, pruritus, and some other stuff. Now, going to doxycycline inhibits, we obviously know this, inhibits the bacterial ribosomal 30S subunit protein synthesis. This is given in chloroquine-resistant states, okay? Now, here is basically what does doxycycline tetracyclines do? Phototoxicity, nephrotoxicity, okay? Now, going to quinine, it's given in the state of resistant, chloroquine-resistant Vivax ovale states, okay, and falciparum. Has a very similar mechanism in terms of heme polymerization. Now, synchronism, we talked about this in the context of anti-rhythmics back in CVP, but basically it can cause tinnitus, headaches, dizziness, nausea, and visual changes, okay? And it can affect other stuff. Now, in also another context, which is in chloroquine-resistant states, you can also give atovaquone, proguanil, or artemether, combination. Here, proguanil will inhibit folic acid, and then the rest will inhibit mitochondrial ETC chain, and most of the mechanism is unknown for artemether. Okay? So yeah. And then you have quinidine, which is used in severe falciparum malaria. And we talked about this in CVP, I think, in terms of what this drug does. Artesunate, free radicals production, and primaquine inhibits, again, not really known. But the thing that I really want you to remember is this drug, we give it in what context? In Vivax ovale infection to treat the dormant forms of the hypnozoids. I want you to remember this by heart, okay? There's a lot of these drugs that I just skipped. I mentioned the side effect and how to treat it and what to give for sensitive. If it's chloroquine sensitive areas, you can give chloroquine. If it's resistant, you can give quinine, and then this drug combination. This primaquine, you give it to treat the dormant forms of Vivax and ovale, okay? High yield, you will get this. A very important side effect is this can trigger G6PD crisis, okay? So for severe malaria, how do you treat it? Artesunate is one of the key drugs. If it's not, then you can start quinine, okay? Uncomplicated, you can give the combination of artemisinin combination. And if it's chloroquine sensitive, as I mentioned, you can give chloroquine or hydroxychloroquine. Now, in non-falciparum, you can treat it, if it's severe and complicated, treat it as this. If it's not, you can give this combination. And Vivax ovale, you need to give Primaquine. You need to give Primaquine. Okay? Now we go to the random organisms. You have this, and let's ignore this one. Go here. What is this? You have vesicles. Ignore this. You have vesicles forming in the mouth. This is HSV. Good. So HSV is a double herpes simplex virus. It's a double-stranded DNA virus. And it commonly has two forms, HSV1, HSV2. HSV1 is in the mouth, oral herpes. HSV2 is in the groin, genital herpes, but they now overlap because of bad practices. And for HSV, it's just important that it causes these vesicles to form in the mouth or the genitals. Later in and the repro, you'll take the genital herpes lecture. Now, another fun fact about herpes is it can lay dormant and cause reinfection again, okay, in the same place. And it can affect also HSV1 can affect, if it's complicated, it can affect hearing, can cause meningitis. Now here, what does this boy have? Diffuse everywhere. Varicella, which is chickenpox. Good. Now, chickenpox is caused by varicella zoster virus. Commonly in children, causes diffuse rash or diffuse vesicles to form in the body. And usually it's treated, what's it called? Supportively. So you just give hydration, rest, don't touch anyone, don't go to school. Now, if a patient if he recovers for the varicella, recovers with chickenpox, later on, 30, 40 years down the line, they have, for example, a dermatoma or rash. What do we call this? Shingles. Okay. This is because of reactivation of varicella zoster. Now, how does this happen? Is varicella zoster basically goes to the dorsal root ganglion and lays dormant there. When you have episode of a stress or immunodeficiency, it reactivates varicella and causes shingles. Okay. That's basically that in a nutshell. Now, how about this? Causes a very severe petechiae and hemorrhage. Crimean Congo hemorrhagic fever. Okay, good. This is a tick that causes it, and it can cause severe petechiae and hemorrhage. Okay, that's all that I think you need to know for this. Now, this one. Yellow fever. What type of virus is it? Flavivirus. Good. What type of virus is a flavivirus? Is it double-stranded DNA? Is it single-stranded RNA? What is it? Positive sense, single-stranded RNA. Excellent. Good. Now it's transmitted by a mosquito. The name of this mosquito is like the whatever mosquito, homologous mosquito, whatever. Then it can cause, what organ is damaged here? Liver. What is this finding? Council in bodies. Excellent. So basically, council in body is a sign of acute hepatitis. Okay, hepatitis is inflammation of the liver, usually due to hepatitis A and some other viruses that you learn in GI. However, one other virus that can cause hepatitis is flavivirus. So flavivirus and any of the viruses, when it causes liver damage, hepatitis, it produces some finding called the council in bodies, which is basically apoptotic hepatocytes. Okay, and it causes budding of the hepatocyte. This is yellow fever virus. Now this one, you have the mosquito, Aedes aegypti, dengue fever. Okay, again, very similar. It causes hemorrhagic fever and very bad disease in terms of dengue. Okay, now I want to give you two contexts before you answer these questions. in number one patient is they have febrile neutropenia. So when they have febrile neutropenia, as I mentioned before, they are immunocompromised and they are more susceptible to infections. The infections that they cause are opportunistic infections. They are infections that happen, for example, in the hospital. In this context, you have these two bacterial causes of infections. What is this one, the green one? Pseudomonas. What is this one? Gram-negative organism. Actinobacter. Excellent. Good. So Actinobacter and Pseudomonas commonly causes infections in a patient with febrile neutropenia or a hospital-acquired infection. Okay. Now, another thing I want you to remember is something called catheter-associated infection. Now, this is mostly in something that we call CLABC infection, which is basically when a patient has a central line. A central line is basically, it's like an IV that you put in the arm, but here. It's just a better format for patients who's long-term, want to give medication. It's just better to do it here. Very importantly, is it can cause very bad infections. Usually, Pseudomonas actinobacter can also be Staph aureus. Okay, this is what CLABC is. Okay, all I want you to remember is these opportunistic hospital-acquired infections can happen to patients with febrile neutropenia in the hospital. And number two is in CLABC infections. Okay. Now these two other organisms, and I think this is my last slide, is other organisms that can cause hospital-acquired infection in febrile neutropenic patient and CLABC infection. This first one is what? Budding yeast cell, keyword, candidiasis. Good. This one, acute septate hyphae with conidia, aspergillosis. Good. Again, these two are common causes of infections in a patient who has severe immunodeficiency. These two like if you have a fungal infection, it's with one of these, with severe immunodeficiency, specifically febrile neutropenia. And again, hospital-acquired infection, specifically CLABC or catheter-associated infection. Okay. With that, I conclude my crash course. Do you guys have any questions? Anything that you want to be clarified? And please scan this code for feedback. Anytime. If you guys have any questions, Allah yafik. If you guys have any questions or anything, you have my contact. Contact me if you need anything, any questions that you have. And inshallah, this was beneficial and best of luck, inshallah, in the exam. I hope it goes well. Thank you, guys.